She presented within the allotted time. So please kindly take your seat behind. You'll be disturbing the other session.
Early detection and containment of communicable diseases. It is important to know that the persistent burden of infectious diseases in Nigeria, characterized by the recurrent outbreaks, especially in this decline of Lassa fever, yellow fever, and cholera, demand highly responsive and technologically integrated community health surveillance systems. However, in our time, there is a severe disconnect between this technological advancement and local operating realities, with the traditional approach plagued by critical inefficiency and time lag between the occurrence of critical events, outbreaks, and the analysis in real time. Now, this study assessed the determinants of AI in disease surveillance use among healthcare workers in primary healthcare facilities in Benin City, Edo State. Methods. An analytical cross-sectional study was conducted among 230 healthcare workers from 23 PHCs in Oregon and Ebo local government area. Now, these facilities were selected using simple random sampling, and the respondents were selected using stratified sampling technique. These constituents of multi-stage sampling technique. Now, the sample size was determined using Cochrane's formula for descriptive studies with a 10% attrition rate. Questionnaire administered was self-administered and standardized. Data was analyzed using SPSS version 25, the confidence interval placed at 95% and statistical significance set at 0.005, less than 0.005. Now, this is a summary of the key findings of this study. The mean age of respondents is as displayed on the screen. All respondents were aware of AI, but the actual uptake in disease surveillance was reported as 7.4% only. Age, marital status, unclear ethical guidelines, smooth integration into surveillance systems, and community trust were determinants of AI uptake. Discussion. Now, this study found that uptake of AI in disease surveillance was very low as less than 1/10 of respondents had ever used AI-based tool for surveillance-related work. Although many respondents knew about AI and had positive attitude towards it, very few had used it in surveillance, though they had used it in clinical or routine work. Now, a probable reason is that AI had not been formally integrated into routine PH surveillance systems in the study area. The use of AI in surveillance systems appear to be driven mainly by individual exposure and self-initiated experimentation rather than institutional deployment. Now, if AI remains at the level of awareness without actual uptake or utilization, its expected benefits for early outbreak detection, faster reporting, trend analysis, and improved response will not be realized at community level. Another important finding of this study is that age and marital status were independent predictors of uptake. Younger and never married respondents were more likely to have used AI tools for surveillance. Now, this may reflect greater digital flexibility within these respondents, more frequent online engagement, more willingness to experiment with new technologies. Now, for ever married respondents, I think they may have had less time for self-directed digital exploration because of work, household responsibilities. Now, this may imply that when AI adoption depends on personal effort instead of institutional training, uptake will naturally concentrate among workers with greater time, confidence, and digital exposure. Now, the implication is that PhD surveillance programs should not depend on spontaneous individual adoption. AI onboarding should be structured, supervised, and accessible to all cadres and age groups within the PhD system. More than 2/3 of respondents reported that unclear ethical guidelines and data privacy concerns limited use of AI in disease surveillance. This finding is important because surveillance systems involve sensitive health information, outbreak alerts, population-level data, and decisions that can affect entire communities. In the absence of clear rules regarding confidentiality, accountability, human oversight, and responsible use of AI-generated output, health workers may be reluctant to adopt such tools, even when they perceive them as useful. It is important that healthcare workers have trust for these systems, because when they do not trust the AI systems that are safe, regulated, and professionally defensible, uptake is likely to remain poor. The study also found that more than half of respondents believe that AI tools were difficult to learn and did not integrate smoothly into existing surveillance systems. This suggests that respondents perceive AI systems as potentially disruptive to routine workflow rather than as tools that naturally fit into existing reporting structures. Implication is that AI implementation strategies should prioritize simplicity, compatibility, and gradual integration into routine workflow. AI systems that increase complexity or disrupt reporting patterns are less likely to be accepted by frontline surveillance personnel within the primary healthcare setting. Successful AI implementation in surveillance will require both institutional trust among health workers and public trust within communities. In conclusion, a significant gap exists between awareness and uptake of AI in disease surveillance among primary healthcare workers in the institute. Systemic barriers, especially lack of ethical guidelines, poor workflow integration, were identified as aspects that will require strengthening. Targeted digital health infrastructure investments and clear governance frameworks are urgently needed. These are my references. Thank you.
Good morning, my professors, consultants, chair and co-chair. My name is Hassan Abdul Rashid, presenting on behalf of our team from the Department of Public Health and Community Medicine, University of Benin. Our study examines the standards of AI chatbot use and its relationship with mental health status among university undergraduates in Southern Nigeria. I'll take you through the outline and rationale, the background and rationale, the methods, the results, discussion, and conclusion over the next few minutes. The transition into university life is a high-risk developmental period where academic, financial, and social pressures converge. Those are young people who are still maturing. The WHO estimates that 1 in 7 young people in 2019 experience a mental health challenge, and globally, over 31% of university students meet diagnostic criteria for a mental health disorder in a given year, with depression the most prevalent. In Nigeria specifically, depression prevalence among undergraduates has been estimated to be around 20-23%, likely an underestimate given the stigma still attached to mental illness. Compounding this, the Nigerian treatment gap is exceedingly wide. The shortage of mental health workers in funded university health centers and care that often only available out of pocket. AI chatbots have emerged as a potentially scalable, low-cost complement to traditional mental health services. They are available around the clock, cost little or nothing, and offer complete anonymity, directly addressing the barriers that that keep students on traditional care. Students are already turning to general purpose AI tools, not just academically, but to manage anxiety, loneliness, and depressive symptoms. So validated platforms like robots and WISA have randomized trial evidence of reducing depressive symptoms, yet remain little known or used. Meanwhile, tools like ChatGPT are what students actually come to, and in Nigeria, we simply lack empirical data on how students engage with these tools or whether it helps or harms them. And that's the gap we set out to address, to assess the dominance of AI chatbot tools and mental health status among undergraduates. We conducted an analytical cross-sectional study among undergraduates at the University of Benin campus. Our population of interest was registered undergraduates. We calculated our minimum sample size using the electric formula based on 33% depression prevalence assumption for prior Nigerian research plus 10% for non-response, giving the minimum of 378. We ultimately surveyed 406 students using a structured self-administered questionnaire. For analysis, we also use the chi-square official exam test for bivalent associations and backward stepwise logistic regression to identify the independence with predictors, with significance set up at p less than 0.05. We had the 100% response rate, 406 respondents in age at about 22. Nearly 80% were aged 18 to 24. AI chatbot uptake was near universal at 97%, and notably close to 60% of respondents screened positive for probable depression, and the striking figure that we will talk to shortly. On specific depressive symptoms, fatigue was the most common, reported by over 70% of respondents, followed by anhedonia and low mood, then sleep disturbance and concentration difficulties. Of great concern, nearly 1 in 3 respondents reported some degree of passive suicidal ideation. Looking at which platform students actually use, ChatGPT dominated at around 86.5%, followed by Gemini and Meta AI. In contrast, technically validated platforms like robots and WISA were used by under 3% of students, and the primary purpose was academic. 94% of these students use these AI tools for schoolwork, and in comparison to only about 12.5% for mental health support. On our bivalent analysis, several factors were significantly associated with depression, which include the younger age, between 18 to 24, the level of study, mainly the 200 level students, on-campus residents, and both AI chatbots dependency and utilization. While gender, religion, faculty, income, and the level of chatbots uptake itself were not significantly associated. After adjusting for other factors and using the stepwise backward stepwise logistic regression, we found out that 5 variables remain independent predictors: age 18 to 24, off-campus residence, which was protective, both age 18 to 25 off-campus residence were protective, AI chatbot uptake, utilization, and dependency. These are the 5 factors that remain independent predictors of depression. Interestingly, uptake itself was protective, but higher utilization and higher dependency both independently raised the odds of depression. Our depression prevalence of nearly 66% is high, exceeding most Nigerian university estimates, likely reflecting converging academic, financial, and psychosocial status alongside limited access to care and pervasive stigma. This underscores the need for proactive routine mental health screening integrated into university services. The finding that 18 to 24-year-olds have higher odds of depression fits developmentally, which is a period of identity formation, academic transition, and growing independence, all converging to heightened vulnerability. Screening and support should prioritize this age window. Off-campus residence was protected, likely reflecting differences in environmental stresses like overcrowding, reduced privacy, and poorer sleep quality common in campus systems. Residential and hostel conditions look like a modifiable structural determinants. AI chatbots uptake itself was protective, likely because most engagement is academic rather than matter of stress. But high utilization and high dependency both independently raise the odds of depression. Suggesting that it is the intensity of the engagement, not just the mere exposure, that drives the risk. And this may reflect a reverse causality with distressed students engaging AI more intensively as a coping mechanism, potentially displacing human connection. Universities need evidence-based guidance on safe AI use and structured digital mental health programs. So in conclusion, depression is highly prevalent, around 60%, that's 9.9%, among university undergraduates. AI chatbot uptake is near universal, but driven by academic and not mental health use. It's high utilization and dependency, not the uptake itself. They are the ones that independently raise depression odds, with age and on-campus residency as key demographic risk factors. Going forward, universities must pair AI accessibility with mental health screening and safe use guidance. Thank you. These are our references.
Thank you.
are moving very fast. So it's now time for the last presenter in this scientific session. Dogo J.A. presenting patient safety, knowledge, and his determinants among undergraduate health profession students in Nigeria. Thank you.
Good morning, professors, distinguished chairs, respected judges, colleagues, and guests. My name is Mune Blessing, and I'm presenting our study on behalf of the author, Knowledge of Patient Safety, Principles, and Associated Determinants Among Clinical Students in Edo State. This work was conducted in the Department of Public Health and Community Medicine, College of Medicine, University of Benin. The clinical training based on the University of Benin Teaching Hospital. Presentation follows the introduction, methods, results, discussion, and recommendation structure. Patient safety is not only a hospital management issue, it's a public health and training issue. Students begin to acquire clinical habits before they qualify, and those habits can either support or undermine safe care. For this reason, undergraduate training is a critical window for building competence in medical safety, infection prevention and control, reporting and learning, vaccination safety, and system-based understanding of errors. The key problem addressed by this study is whether clinical students have adequate patient safety knowledge and which educational or clinical factors are associated with better knowledge. The study gap is straightforward. Although patient safety is a global priority, undergraduate exposure is often inconsistent, especially across different health professional programs. Our aim was therefore to assess the level of patient safety knowledge and identify the determinants of good knowledge among clinical students. The outcome was dichotomized using studies' predefined cutoff. A score of 50% or above was classified as good knowledge, while a score below 50% is classified as poor knowledge. I will interpret this carefully because meeting the cutoff should not be mistaken for full mastery. This was a descriptive cross-sectional study. The participants were clinical students from 5 health professions program, includes medicine, nursing, medical laboratory science, physiotherapy, and paramedics. They came from 3 institutions: University of Benin, Benson Dausa University, and Wellspring University, and were undertaking their clinical rotation all at the University of Benin Teaching Hospital in Benin City. A stratified random sampling approach was used with program of study as stratification variable. The minimum sample size was 623, and the final number of respondents was 637. Data was collected using a pre-tested structure questionnaire adapted from the WHO Patient Safety Curriculum Guide. The knowledge assessment covered 5 domains, including medical safety, infection prevention and control, reporting and learning system, vaccination principles, and system-based understanding of errors. The analysis was conducted using the IBM SPSS Statistics version 27. Descriptive statistics summarized the data by variant associations were assessed with chi-square or features exact test as appropriate. Variables with a p-value below 0.2 were entered into the multivariate logistic regression model, and statistically significance was at p-value less than 0.05. A total of 630 undergraduate health professional students participated, with mean age 23.4 years, with a standard deviation of 2.0 years. Slightly more than half of the respondents were females, representing 52%. The study included students from medicine, nursing, medical laboratory science, physiotherapy, and paramedic program. Although the students were drawn from 3 different institutions, their clinical rotation exposure was at the University of Benin Teaching Hospital, creating a shared clinical training context. The first key result is that 478 students, representing 75% of all respondents, met the study-defined threshold for good patient safety knowledge. The remaining 159, 25%, were classified as having poor knowledge. This is encouraging because most students have foundational knowledge. However, it should be interpreted cautiously. The cutoff of good knowledge was 50% or more of the maximum score. So these findings should show adequate baseline knowledge rather than complete mastery of patient safety principles. When knowledge was examined by domain, the highest proportion of good knowledge were observed for system-based understanding of errors at 84%, and medication safety at 84%. Vaccination principles followed complete mastery of patient infection prevention and control at when knowledge was examined by domain, the highest proportion of good knowledge were observed for system-based understanding of errors was reported at 84%. And the medication safety, patient safety at 84%. Depending on vaccination principles followed complete mastery of patient infection prevention and control at when knowledge was examined by domain, the highest proportion of good knowledge were observed system-based understanding of errors was reported at 84% patient safety. And the medication safety, patient safety at 85%. Depending on vaccination principles followed complete mastery of patient infection prevention and control at when knowledge was examined by domain, the highest proportion of good knowledge were observed system-based
welcome again to our 4th annual College of Medical Sciences Scientific Conference 2026. This is just to announce that the program is e-copied, so you can scan the barcode on your tags to get a copy of the program. In case you do not have a hard copy, there's an e-copy of the program, which is the barcode of your tag. You can scan it to have a copy. Thank you. morning, everyone. We want to welcome you again to the 4th Annual Scientific Conference of the College of Medical Sciences. While we wait for official starting, this is just to remind us that the copy of the program can be scanned from the barcode on your registration tag. So if you do not have a hard copy of the program, please feel free to scan the e-copy on your registration tag. If you haven't registered, please, the registration desk is on my right outside. You can just go there quickly and sort out your registration. If you need to take pictures at the photo booth, is on my left hand side. We would like for our very respected teachers and trainers to move forward as much as possible so that we can see you for recognition. But we want to welcome you all very specially and thank you for making our time to be here with us for this event. We will start in a bit.
Ladies and gentlemen, it's a great delight to welcome you one more time to the 4th Annual Scientific Conference of the College of Medical Sciences, University of Benin. It's a pleasure having you here this morning. Thank you for your patience. Thank you for all the sessions that has gone on before now. And to also let you know that the rest of the day throughout today is not going to be wasted. My name is Tracy Omoragon. I am of the Public Relations and Protocol Unit of the Vice Chancellor's Office here at the University of Benin. I am anchoring this program alongside Dr. David Orewere. We welcome you. At this time, ladies and gentlemen,
I want to welcome the principal officers of the University of Benin. As they get seated, we'll properly introduce them.
Ladies and gentlemen, please let's all be upstanding to take the national anthem, and thereafter we'll take the Uniben anthem. Uniben. Greatest Uniben. Great. Thank you. Please be seated. Thank you very much. We'd like to welcome to this 4th annual scientific conference of the College of Medical Sciences, University of Benin, our Vice Chancellor, a person who has a very wonderful antecedent. Everywhere he goes is about new things happening. He's a pace setter. He has transformed things around the University of Benin and beyond, things that we can see in terms of capacity, infrastructure, welfare, and academically. Ladies and gentlemen, let us welcome Professor Edoba Omoyege, Senior Advocate of Nigeria, our Vice Chancellor, here represented at this scientific conference by our Deputy Vice Chancellor Administration, Professor Christopher Osubo. Also with the Vice Chancellor this morning, we have our Deputy Vice Chancellor in charge of academic. Let us welcome very warmly a Professor and a Chief, Professor Chief Victor Ogiegbeneweka. We also have on the entourage of the Vice Chancellor, the keeper of the university's monies. Ladies and gentlemen, without money, this conference will not be looking the way it is now. You can see the ambience around this place, very beautiful. Let us welcome the bursar of the university, Mr. Osagi Osifo. We also welcome our ebullient registrar. She's here seated, represented at this very conference by our Deputy Registrar in charge of establishment. Please let us welcome Mrs. T.M. Omage-Ome. We also have on the Vice Chancellor's entourage this morning, the librarian of our university, the keeper of our books. Please let us warmly receive Professor Jane Abba. We welcome you, ma'am. We also like to take a place on this high table with our Vice Chancellor, our keynote speaker for today. He is the Permanent Secretary, the General of Services Office of the Secretary to the Government of the Federation. Ladies and gentlemen, let us warmly welcome, with the Uniben spirit, Dr. Abraham Kama, MNIM. Please let us welcome him. We need an usher to take him off stage. We are going to keep clapping until he gets to his seat here off stage. Our keynote speaker for this phenomenal 4th scientific conference of the University of Benin College of Medical Sciences. Welcome you, sir. Welcome to the University of Benin. Already seated on a high table is the provost, our provost, your provost, the provost, College of Medical Sciences, University of Benin, Professor Wilson Sado, who is at this event represented by the very powerful, vivacious Deputy Provost, Professor Vivian Omwemo.
All right, so we are going to acknowledge some more guests here as we constitute the high table properly. We want to make welcome and bring to the high table the Dean, School of Medicine, College of Medical Sciences, University of Benin, Professor Wilson Osaeti Osaogiagbon. You're welcome, sir. Please let's bring him up to the high table. On the other side.
Please let us take him up to the high table.
We have also here with us our Dean of the School of Dentistry, my teacher and trainer, Professor Joan Emien Enabulele. Please let's welcome her to the high table this morning. We have the Dean of the School of Basic Medical Sciences, Professor Humphrey Osadolo. Professor Humphrey Osadolo, please let's welcome him to the high table if he's here. We also have with us the Dean of the School of Basic Clinical Sciences. I'd like us to welcome to the high table Professor V. Ekanem. Okay, he's just joined us.
Professor James Ekanem, we welcome you, sir.
Welcome, sir. Please, let's bring him up to the high table as well. We have the director of the Institute of Child Health, Professor Ayebo Sado. Please, let's welcome Professor Ayebo Sado to the high table, if she's here. The Deputy Registrar and College Secretary, Mrs. Agnes Ndidi Ukon. Please, let's welcome her to the high table. Our Deputy Registrar and College Secretary. We want to welcome some of our distinguished trainers to join the high table on request.
Ladies and gentlemen, I want us to welcome, as we receive to this other side of the days, a former Deputy Vice Chancellor Academic of our university and a foremost medical practitioner. Please let us welcome Professor Michael Aziken. We welcome you, sir. Please, you are requested to come up stage here.
Professor Aziken to the high table, please. Please, let's help Professor Aziken to the high table. All right, we also want to welcome the Dean of the Faculty of Nursing, Professor Okafor. Please, let's welcome Professor Okafor to the high table. Professor Okafor to the high table, sir. Thank you, sir.
Thank you, Professor Fidelis Okafor. We're happy to have you at this conference. Ladies and gentlemen, we are not just going to do the normal clapping like we are doing now. I want a warm applause as we receive this next personality to this other side of the days. Ladies and gentlemen, please join me to welcome. Please join me to receive to this side of the auditorium, a foremost gynecologist, a former DCMAC of the University of Benin, Teaching Hospital. Please let us welcome Professor Alfred Ehigiegba.
Professor Alfred Ehigiegba to the high table,
please
sir.
Please keep clapping.
Welcome you, sir. Especially.
Until he will get up here.
Please, we want to request those sitting behind to please move forward so that we can have good coverage of this event. Please, if you are sitting behind, please just move forward. Let's occupy the seats. If they are not reserved seats, please let's occupy them in front, please.
Thank you, ladies and gentlemen. We want to quickly recognize and welcome ladies and gentlemen, a former Commissioner of Health, Edo State, and presently the Provost, College of Medical Sciences, Benson Idahosa University. Please join me to receive very warmly Professor Moses Momo. We welcome you, sir. Always good to have you in our midst. Another reason why we have to applaud Professor Momo is that his wife, his better half, Professor Mrs. Rita Momo, is the LOC chair of this 4th scientific conference of the College of Medical Sciences. We also want to welcome and recognize the presence of Professor Iyekoreti Ewoma. We welcome you. Professor Iyekoreti Ewoma, we welcome you, sir. We also welcome Professor Beck Sahid. We welcome you, sir. Former Dean of the School of Dentistry. We welcome you, sir.
We also have here with us a former Dean of the School of Dentistry, Professor Ausagie Akpata. You're welcome, sir. Thank you for joining us this morning. We also want to make some other very special welcomes before we advance this program further. We have here in our midst a retired professor of physiology, teacher and trainer, Professor Abo D.A. Igoroje. You're welcome, Professor Abo Igoroje. You're welcome. Thank you for coming around to join us for this program. We want to also welcome to the high table the college accountant, Mrs. Mary Ibade Ikisemoje. Please, Mrs. Mary Ikisemoje, I want you to come up to the high table to join. Thank you, ma. From the Department of Physiotherapy, Uniben, we have here with us Professor Kayode Oke. Professor Kayode Oke, you're welcome, sir. Thank you for joining us for this program this morning. We we have here with us, representing one of our partners and sponsors for this program, from Nuga Oil and Farms, Victor Ime Ojekere. You're welcome, sir. Thank you for joining us. We'll make more recognitions as we get the names, so please bear with us. We'll make more recognitions as we get the names. I want to very specially appreciate, because she'll join us very quickly to give her opening remarks, the chairman of the local organizing committee for this conference, a very capable and distinguished ophthalmologist by training, Professor Rita Momo. Let's celebrate Professor Rita Momo this morning. We'll welcome her in a bit to give her opening remarks. But before that, we'll make some more. To make progress in today's event, we're going to welcome right up stage the chairman of the local organizing committee for the 4th annual scientific conference of the College of Medical Sciences, consultant ophthalmologist, Professor Rita Momo. Let's put our hands together for her as she takes the podium. Thank you.
The Vice Chancellor, ably represented by the Deputy Vice Chancellor, Academics, our Chief Host, the Provost of the College of Medical Sciences, our host, and visionary behind this gathering, ably represented by the Deputy Provost, Professor Vivian Omwemu, our special guests of honor, whom we're still expecting, principal officers of the university, our distinguished keynote speaker, Dr. Ibrahim Kana, special guests, heads of institutions, deans, directors, and heads of department, distinguished retired academics, panelists, presenters, invaluable sponsors and partners, esteemed professors and academics, distinguished guests, students, ladies and gentlemen, good morning and welcome. It is my singular honor and privilege as chairman of the 4th annual conference of the College of Medical Sciences to formally welcome you to what I believe will be one of the most important conversations our college holds this year. We gather under a theme that is both a diagnosis and a prescription, breaking silos, strengthening medical education and health through collaboration. Disease does not respect departmental boundaries, and neither should our response to it. The clinician, the scientists, the public health experts, the policymakers, and many others are in truth working on the same patient and on our future. All of us are involved, often without speaking to one another. This conference hopes to change that. Our conference actually started with a pre-conference workshop where we trained over 50 persons, medics, scientists, and students alike, on a basic skill which all of us have, or rather ought to have, on hands-on cardiopulmonary resuscitation. It was done simply as a community give back. Our conference program moves deliberately from inspiration to implementation. We had almost 60 abstracts submitted, so we began with oral paper presentations, and have also accepted poster presentations for the first time, and we have 14. At our plenary sessions, we'll look at the role of artificial intelligence and digital tools in transforming medical education and healthcare delivery, a transformation that is already underway, but which now demands that we lead rather than lag. We then turn to a conversation that we often talk about along the corridors, the journey from data to paper, and the integrity that must anchor it. In an era where credibility of science itself is under scrutiny, this is not a technical footnote, but a foundation that must be reiterated. We take a look at the art and craft of grant writing, demystifying what is often viewed as complicated and difficult to achieve. We conclude with an interprofessional panel on how to collaborate effectively. And in all of these sessions, we bring on board the finest experts, guided and anchored by senior and experienced faculty. We are honored this morning to welcome a keynote speaker of exceptional distinction, my resident classmate, a respected medic, a high-level administrator, and civil servant whose career sits precisely at the intersection this conference is built around: medical science, policy and practice, grassroots impact governance. Dr. Ibrahim Abubakar Kana, MNI, your presence here affirms that this conversation extends beyond our campus, and we await your remarks with great anticipation. Over the next 2 days, we will be building bridges between disciplines that have long worked in parallel. I urge you, do not miss any session. We assure you of gourmet meals and refreshments to keep you safe and comfortable through each day's business. To our chief host, I now have to thank many persons that have contributed in supporting this program. Our chief host, the Vice Chancellor, Professor Edoba Bright Omorege SAN, we're immensely grateful, sir, for your unwavering support and encouragement for academic excellence, and particularly this conference. To our host, the Provost of the College of Medical Sciences, the conference is actually your brainchild, and we're just privileged to bring it to life. We acknowledge with gratitude the financial and moral support of the CMD of UBTH, Professor Idia Nibokun Izeyamu, MD Specialist Hospital, MD Edo Specialist Hospital, Pastor Sage Izeyamu, and other Uniben medical alumni who supported us tremendously at this conference. To our industry sponsors and funding partners, we thank you for investing in academic development and health. We acknowledge with gratitude our gold and silver category sponsors: Nuga Oil and Gas, Nuga Agro and Farms, FitSing, SynLab Nigeria, Shalom Dental Center, and Professor Mike Okorie, who in addition to financial support joins us as a speaker from the UK to offer his expertise. He's supposed to join us about 12:31 for the session on AI and digital tools. To the most amazing organizing committee and support staff, their tireless efforts is visible in every detail of what is about to unfold. We say thank you. To our supportive families behind the scenes, and at this point, I want to especially thank my husband, the Provost of Benson Idahosa University College of Medical Sciences, Professor Moses Momo, for his wonderful support. Very cute support behind the scenes. To every researcher and professional who submitted an abstract or paper, thank you for trusting us with your scholarship. And to each of you seated here, thank you for choosing to be a part of this conference. On behalf of the organizing committee, I most warmly welcome you to the 4th annual scientific conference of the College of Medical Sciences. To God be all the glory. Thank you very much, and God bless us all.
Thank you very much. That's the able chair. Very astute, so hardworking. I received a message from her one morning at 3 a.m. or thereabout. I was like, wow, is Prof not sleeping? And then she gets everything done. This morning, as at 7 a.m. or so, persons were already in this place. Please, let's celebrate her one more time. Very hardworking, very dedicated. Thank you very much, ma. At this time, ladies and gentlemen, it's time to hear from the Provost, College of Medical Sciences, University of Benin. Let us warmly receive to our midst, I will always address her as the vivacious Professor Vivian Omwemo, the vivacious Professor Vivian Omwemo, as she brings the warm address from the Provost.
The chairman of this occasion, our dynamic Vice Chancellor, Professor Edoba Bright Omorigi, SAN, ably represented by the Deputy Vice Chancellor Admin, Professor Chris Osumbo. Other principal officers, our keynote speaker, Dr. Ibrahim Abubakar Kana, MNI, staff, academic staff, senior academic staff, retired academic staff, non-academic staff here present, other special guests here, and our great Uniben students. Distinguished ladies and gentlemen, I welcome you all. The Provost would have really liked to be here, but is unavoidably absent and he sends his apologies. So I'll read his welcome address. I'm very pleased to welcome you all to the opening ceremony of the 4th Scientific Conference of the College of Medical Sciences, University of Benin. The college has grown since the last conference to include programs including occupational and speech therapy. We appreciate our Vice Chancellor for these developments. The college has refurbished its boardroom, the Provost Conference Room, and created a postgraduate seminar room complete with modern facilities and furniture, and to improve atmosphere to have meaningful classes. We are grateful to our medical alumni who have contributed towards the successful execution of these projects. The theme for this year's conference is Breaking Silos, Strengthening Medical Education and Health Systems through Collaborations. The importance of this theme cannot be overemphasized, as collaboration is needed to focus on the efforts of the various disciplines within the college to achieve success in improving the standard of care of our people. The contents and quality of our abstract should now transition into our collaborative efforts that will present solutions to the myriads of health-related problems afflicting our people. It is also an opportunity to win one of the many prizes available, from the Provost Prize to the several Dean's Prizes backed up with cash. I think all the deans have Dean's Prizes for their various schools. So get ready with your great abstracts and make an award-winning presentation. The abstracts will be included in the book of proceedings that will be published in our college journal to ensure that we count towards promotion. This year, our guest speaker is Dr. Ibrahim Abubakar Kana, MNI, and a fellow of the Medical College in Ophthalmology, a permanent secretary, General Services Office of the Secretary of the Government of the Federation. We welcome you, sir, to the University of Benin to deliver the lecture from his perspective. We are grateful to him for accepting our invitation as guest speaker. The college is grateful to the College Conference Local Organizing Committee led by Professor Rita Momo, who together with her team has put together a wonderful conference complete with a pre-conference workshop on hands-on training in basic life support. The college is deeply grateful to Fitin Pharma, who have graciously sponsored the workshop. I also want to quickly thank all our deans and directors in the college for the support they have been giving so far in kind and cash. We acknowledge with grateful hearts the financial and moral support received from the Vice Chancellor of the University of Benin, Professor Edoba Bright Omorege, SAN, the Chief Medical Director of UBTH, Professor Idia Izeayamu, and the medical directors of many health facilities in Benin City, our friends and alumni who have contributed to the success of this conference. Finally, I wish us all fruitful deliberations in this conference. Thank you, Professor Wilson Sadu. Thank you.
Thank you, Ma. Let's celebrate her one more time. That's the Deputy Provost of the College of Medical Sciences, Professor Vivian Omwemo. Thank you very much, Ma. She's here representing the Provost, Professor Wilson Sado, and you just listened to the Provost welcome address. Right away, we're going to take the welcome remarks from the Vice Chancellor of the University of Benin, Professor Edoba Bright Omorege, SAN. He is here represented by the Deputy Vice Chancellor Admin, Professor Christopher Osubo. Please let's welcome him as he comes to give the remarks for the Vice Chancellor.
Principal officers of the university here present, the keynote address speaker, Dr. Kana MNI, the Provost College of Medical Sciences, ably represented by Professor Mwemu, the deans here present, professors, distinguished professors, serving and retired, staff and students of this great university, ladies and gentlemen. The Vice Chancellor, Professor Edoba B. Omorege, Senior Advocate of Nigeria, would have loved to be here, but he's away on official assignment, and he has asked me to represent him. I will now read his address on this occasion. It is with great pleasure and privilege that I welcome you all to this fourth annual scientific conference of the College of Medical Sciences, University of Benin. The theme for this year is Breaking Silos, Strengthening Education and Health Systems Through Collaboration. Is both timely and strategic. Distinguished ladies and gentlemen, no profession can solve the health issues confronting the 21st century. There is need, therefore, to work across disciplines, and this challenges us as a university and as a health community to move beyond disciplinary boundaries, to teach, research, and deliver care in an integrated manner. Complex health challenges of the 21st century cannot be solved by a profession working in isolation. Basic sciences must inform clinical practice, and which must in turn generate research questions for the laboratory. This is what this scientific conference sub-themes seek to address. In this era where artificial intelligence and digital tools are no longer peripheral to teaching and care, it is imperative to train a workforce that is both digitally competent and critically reflective to technological enhancement rather than replace clinical judgment. Strengthening the health system requires intentional collaboration between academia, teaching hospitals, professional bodies, government, and industries. For a country with resource-constrained settings like ours, partnerships are essential to fill the gaps in training, retention, and deployment of health workers that will meet the growing population needs. I charge the college to ensure that the collaborations initiated here translate into concrete outcomes that advances the cause of this institution to its peak. The future of health belongs to students. They are not just future doctors, but a powerful force of change that will bridge the gaps in Nigeria's healthcare system from the classroom to the community. On this note, distinguished ladies and gentlemen, I wish you a successful conference as I declare this 4th annual scientific conference open. Thank you very much. Professor Nomado Okorede, Vice Chancellor.
I want to thank the Vice Chancellor of the University of Benin, Professor Edoba Bright Omorige SAN, represented by the DVC admin, Professor Christopher Osubo. Before we go into a quick interlude to be handled by a cultural troupe from the University of Benin Teaching Hospital, IHT, we want to make some more recognitions here. We have here with us the Deputy Chairman of the Nigerian Medical Association, Edo State, representing the Chairman, Edo NMA, Dr. Oduwari Ehiyegba. You're welcome, sir. Consultant Obstetrics and Gynecology. You're welcome, sir. We have here with us as well the Chief Executive Officer, Edo Healthcare Regulation and Monitoring Agency, Edo HEMA, Dr. Adesuwa Orogide. Edigin, you're welcome, ma. Good to have you around.
Welcome, ma.
We have the Chairman of the Nigerian Association of Medical and Dental Academics, Professor Alphonsus Isara. You're welcome, sir. Good to have you around, sir. We also have the Chairman of MedSabams Uniben. He's also the National President of MedSabams Uniben, Dr. John Anyoye. You're welcome, sir. Thank you for joining us for this event. We have very well with us one of our latest professors, a very distinguished leader at that, the Center Leader and Director of SERI Uniben, Professor Oba Isiagbon. You're welcome, ma'am. Thank you for coming around. We also have with her the Deputy Center Leader, Professor Mrs. Enuku. You're welcome, ma'am. Thank you for joining us for this event.
I also like us to receive, ladies and gentlemen, a former Deputy Vice Chancellor Administration of our university, Professor Mrs. Catherine Okmowa. We welcome you, ma. She has come to support our fellow ophthalmologists. Welcome, ma. We also want to welcome very specially Professor Stefina Igedosa. We welcome you very specially, ma. Thank you for making our time to be here for this 4th annual conference.
Just joining us, we have the first female Dean of Dentistry, Professor Alice Uweni. You're welcome, ma. Thank you for joining us for this event.
At this time, ladies and gentlemen, let us remind you that you are in the land of Edo, a place of rich cultural heritage, as we invite to take the stage to entertain for only 5 minutes the student from IHT UBTH. You're welcome. Please take the stage.
working yo. E mommy ne e moya working yo. Gayeru sway. Omo na enegbe no. Gayeru sway.
Hey!
Let's have Thank you so much. All right, we're still on at the 4th Annual Scientific Conference of the College of Medical Sciences, University of Benin, and the theme is Breaking Silos, Strengthening Education and Health System Through Collaboration. Breaking Silos talks about partnerships, talks about collaborations, talks about doing things on your own to coming out to help people and get people to assist you to do things differently. All right, like you noticed at inception, the College of Medical Sciences just had about 2 schools, medicine, dentistry, and then the Institute of Child Health. But now we have the School of Clinical Medical Sciences, we have the School of Basic Medical Sciences, we have the Faculty of Nursing Sciences. And there's a lot of collaboration that has to go on between all of these schools. And that's what our keynote speaker this morning is going to speak to. As has been introduced already, our keynote speaker is Dr. Ibrahim Abubakar Kana, MNI DRM. To give his citation, before we get into the keynote lecture, I want to welcome to the podium this morning, Professor of Community Medicine and Public Health, Professor Andrew Obi. Let's put our hands together to receive him this morning.
Thank you very much, our dear Vice Chancellor, standing on the well-established protocol. My job this morning is simple: to read the keynote citation of the keynote speaker, and I'll do justice to that. Sir, if you could please be upstanding. Dr. Ibrahim Abubakar Kana, MNI DRM. Thank you. Is a distinguished public sector administrator, consultant, ophthalmologist, policy strategist, and transformational leader whose career spans medicine, public health administration, defense, aviation, and the highest levels of Nigeria public service. He currently serves as Permanent Secretary, can we put our hands together for him? General Service Office of the Office of the Secretary to the Government of the Federation of Nigeria, where he provides strategic leadership in coordinating critical government functions and advancing national government priorities. Before his current appointment, Dr. Kana served with distinction in several strategic national institutions, including the Federal Ministry of Health, where he served as Special Assistant to the Minister of State Health, and several permanent secretaries. In the Ministry of Health, he played pivotal roles in health policy formulations, Nigeria's response to the Ebola virus disease outbreak, the domestication of the Millennium Development Goals, COVID-19 response, where he served as project director of the President Muhammadu Buhari Restore Visions project, through which over 10,000 cataract surgeries were successfully carried out across the country. He has also coordinated the Nigeria Hajj Medical Mission and subsequently served as the National Program Manager for the $500 million World Bank project Saving 1 Million Lives program for results. The first results-based health financing government health program focusing on maternal and child health in Nigeria. Thought we'll put our hands together for him. As Permanent Secretary, he served in the Ministry of Defense and the Federal Ministry of Aviation and Aerospace Development, where he distinguished himself through visionary leadership, institutional reforms, and administrative excellence. Popularly described by colleagues and associates as the bureaucratic soldier doctor, Dr. Kana has earned a reputation for approaching public administration with media-like discipline, carefully crafted strategies, and exceptional attention to detail as the physician he is. He is known for handling complex administrative responsibilities with remarkable swiftness, diligence, and regimented precision. consistently delivering results while upholding the highest standards of accountability, professionalism, and public service. Dr. Ibrahim Kana has contributed in many scientific publications during the course of his academic and professional career in Ahmadu Bello University and Usman Danfodio University. He's a fellow of the National Postgraduate Medical College of Nigeria. He's a proud member of the prestigious National Institute for Policy and Strategic Studies, Kuru. Can we put our hands together for him? He attended several health financing and leadership courses by the World Health Organization, the World Bank, the Malaysian Institute of Management, and the Johns Hopkins University, United States of America. As a unionist, he was president of Jos University Medical Students Association, national president of the Nigeria Medical Students Association, NIMSA, national treasurer of NMA, and many more. During his formative years, he visited the world campus of the University of Benin several times and addressed the great Uniben students, so he feels very much at home here today. Throughout his distinguished career, he has demonstrated outstanding expertise in governance, public administration, organizational management, stakeholder engagement, regulatory compliance, legislative process, and intergovernmental relations. He is widely respected for building and motivating high-performing teams, fostering collaborative workplace cultures, and maintaining enduring partnership with government institutions, development partners, and other critical stakeholders. His exceptional communication skills, strategic vision, willingness to embrace new challenges, and dedication to continuous learning has established him as one of Nigeria's most accomplished senior public servants. Dr. Kana has visited all the continents of the world, touching base in over 50 countries, and his hobbies include reading, mentoring young people, playing badminton, watching football. He's married to one wife, Zainab, and blessed with high-achieving children, including a commercial pilot who's made first class in aerospace engineering with pilot studies at the University of West of England, an architect, a medical student, and a set of twin boys. Can we put our hands together while we stand up to welcome to this podium the keynote speaker for the 4th College of Medical Sciences Conference, Dr. Ibrahim Abubakar Kana, MNI, DRM. Thank you very much, sir. Thank you very much.
The Vice Chancellor of this great university, the principal officers of the great University of Benin, permit me to specifically recognize the registrar of this university because my father retired as the registrar of a university in Nigeria. Provost of the College of Medicine, professors here present, permit me again to recognize our own wife, the friend of my bosom friend, Esaho and Abulele, whose wife Joanne is here today as a professor. We married Joanne many years ago. The great students of University of Benin, distinguished guests, ladies and gentlemen. I am deeply honored to be invited to deliver this keynote address on a subject that is not only timely but fundamental to the future of healthcare delivery in Nigeria and across the African continent. Permit me to single out my own schoolmates, Professor Rita Momo, and of course her husband, Professor Momo, who made sure, and I insist, Rita made sure I returned to Benin, my own home. Coming back to Obowo campus, since my arrival yesterday, brings back lots of memories to me, good memories of the great Uniben. As a student union leader during my time, I had the singular privilege of addressing the great students of Uniben in those days, and at other times represented my university at the West African University Games hosted by the University of Benin. I am particularly honored by the Vice Chancellor and Provost of the College of Medicine for identifying me out of millions of Nigerians to deliver this lecture. The theme or lecture I'm delivering today, Collaborating for Impact, aligning medical education, health systems, and policy to build a resilient healthcare workforce. This speaks directly to one of the most pressing challenges confronting our nation today. The significance of today's discourse extends far beyond medical education or the health sector. It speaks directly to Nigeria's aspiration to build a productive, healthy, globally competitive population that is capable of driving sustainable national development. It is therefore fitting that this conference has chosen collaboration as its central theme. Collaboration is a currency of resilient health systems. No single institution, I insist, no single institution, whether government, academia, professional associations, development partners, or healthcare partners or healthcare providers can independently provide the workforce required for 21st century healthcare. Success will depend upon purposeful partnerships, shared accountability, continuous innovation, and collective leadership. The strength of any healthcare system is determined not merely by the number of hospitals it possesses, the sophistication of its technology, or the volume of resources invested in it. Ultimately, the success or failure of health systems depends on the people who make it work. And these include the doctors, the nurses, the pharmacists, laboratory scientists, community health workers, researchers, administrators, and policymakers collectively constitute the human infrastructure upon which healthcare delivery actually rests upon. The outline of my presentation today is as shown on the screen. The aim of this presentation is to apprise the Nigerian health ecosystem with focus on medical education, the health system, and policy-making system. Let us begin with the Nigerian health workforce reality. Any serious discussion about healthcare workforce resilience must begin with an honest appraisal of our current reality. Nigeria today stands at a critical crossroads with an estimated population exceeding 230 million. Our healthcare needs are growing at a pace that places enormous pressures on existing human resources. Despite producing thousands of health professionals annually through our universities and training institutions, the country continues to experience significant shortages and maldistribution of healthcare workers. Paradoxically, Nigeria is internationally recognized for producing highly skilled health professionals who excel in virtually every healthcare system around the world. Nigerian doctors, Nigerian nurses, the pharmacists, laboratory scientists, and other health professionals also occupy leadership positions in renowned institutions across Africa, Europe, North America, the Middle East, and the Oceania. The challenges before us, therefore, is not one of intellectual capacity or educational potential. It is the persistent inability of our health system to attract, equitably deploy, motivate, and retain this valuable human capital. Consequently, millions of Nigerians face barrier to accessing quality healthcare services close to where we actually live. The World Health Organization estimates that nearly half of the global health workforce serves only about 1/5 of the world's population, underscoring profound inequities in workforce distribution. Nigeria mirrors this imbalance, indeed internally. While tertiary hospitals in major cities continue to attract specialists, like we have many here today, many primary healthcare centers in rural and conflict-affected communities remain critically understaffed, thereby undermining equitable access to essential health services and the realization of our dream, which is the universal health coverage. This imbalance has important implications beyond healthcare delivery. It reinforces social inequities, fuels preventable morbidity and mortality, weakens public confidence in health institutions, and ultimately constrains national productivity. A resilient healthcare workforce must therefore be judged not merely by its size, but by its accessibility, its acceptance, its competence, its responsiveness, and indeed equitable distribution. The events of recent years have reminded us of this reality with remarkable clarity. The COVID-19 pandemic exposed vulnerabilities in health systems around the world and demonstrated that even the most advanced countries are only as resilient as their healthcare workforce. Nations with strong workforce planning, effective training systems, and supportive policies were able to respond more effectively than those where workforce development had been neglected. For Nigeria, the lessons are particularly relevant. Our country continues to experience rapid population growth, epidemiological transitions, increasing urbanization, and a rising burden of both communicable and non-communicable diseases. These realities place unprecedented demands on our healthcare systems and require a workforce that is not only competent, but adaptable, innovative, and indeed resilient. Yet, despite the remarkable achievements of our medical schools and healthcare institutions, we continue to grapple with significant workforce challenges. We face shortages of skilled personnel in many areas of our dear country. We confront the persistent challenges of migration of health professionals to other countries, what some call the Japa syndrome. We struggle with inequitable distribution of healthcare workers between urban and rural communities. We also face the challenges of ensuring that our educational systems keep pace with emerging technologies and evolving healthcare needs. While migration is often portrayed solely as a challenge, it is also a reflection of the global competitiveness of Nigerian health professionals. The objective of national policy should therefore not be to restrict mobility, but to make Nigerians sufficiently attractive that our best minds choose to build long, fulfilling, and impactful career at home. Competitive remuneration, safe working environments, opportunities for specialization, merit-based career progression, research funding, and supportive institutional leadership are among the critical determinants of workforce retention. Equally important is the need to strengthen workforce intelligence. Countries with resilient health systems routinely use integrated health workforce observatories, digital registries, and predictive analytics to forecast workforce needs, identify emerging competency gaps, and guide policy decisions. Nigeria must progressively develop similar evidence-based workforce planning systems, which is capable of informing educational investments, recruitment strategies, and long-term health sector planning. Addressing these challenges requires a new way of thinking. It requires us to move beyond isolated interventions and embrace collaborations as a strategic imperative. The future of healthcare workforce development lies at the intersection of three critical domains. 1, medical education. 2, the health systems. And lastly, public policy. Now, let's look at the medical education policy. Medical education serves as the foundation upon which the healthcare workforce is built. Colleges of medicine and other health training institutions have the sacred responsibility of preparing future professionals who will care for our citizens. These institutions shape not only clinical competence, but also professional values, ethical standards, and leadership capabilities. The quality of training received today will determine the quality of healthcare delivered tomorrow. The World Federation for Medical Education emphasizes that excellence in medical education should be measured not only by academic achievement, but by the ability of graduates to respond to the health needs of its own society. Medical schools, therefore, have a social accountability obligation to align education, research, and service with national priorities. Therefore, medical education cannot exist in isolation from the realities of healthcare delivery, indeed, of our country. The healthcare environment is changing rapidly, advancing in digital technology, artificial intelligence, genomics, telemedicine, and precision medicine are transforming the practice of medicine globally. New diseases continue to emerge while existing health challenges become increasingly complex. Consequently, educational curricula must evolve continuously to remain relevant. The physician of the 21st century requires competencies that extend beyond clinical practice. Today's healthcare professionals must be effective communicators, collaborative team players. They must be technologically literate practitioners. They must be critical thinkers and adaptive leaders. Medical schools must, therefore, ensure that graduates possess not only knowledge, but also the practical competencies required to function effectively in contemporary health settings. Equally important is interprofessional education, where medical students learn alongside nursing, pharmacy, dentistry, physiotherapy, laboratory science, and other health professional students. Such collaborative learning fosters mutual respect, strengthens teamwork, and improves patient outcome, which really is our ultimate goal. Equally important is the role of health systems themselves. Hospitals, primary healthcare centers, specialist institutions, and public health agencies serve as the environment in which healthcare professionals apply their knowledge and refine their skills. These institutions influence professional growth, workforce satisfaction, and career development. They are therefore indispensable partners in workforce development. Unfortunately, ladies and gentlemen, in many instances, a disconnect exists between educational institutions and healthcare delivery systems. Training programs may not always reflect the realities encountered in practice. Graduates may enter the workforce insufficiently prepared for the challenges they face. I'm sure many professors will agree with me. Healthcare institutions may struggle to provide the mentorship, support, and career pathways necessary for professional development. This disconnect often manifests as what educational experts describe as a theory-practice gap. Students may graduate with excellent theoretical knowledge, yet feel inadequately prepared to navigate the complexities of real-world clinical practice. Conversely, healthcare institutions frequently expect newly qualified professionals to perform at levels for which they have received limited practical exposure. Bridging this gap, therefore, requires continuous dialogue between the universities, the teaching hospitals, the regulatory bodies, and indeed the employers. To address these gaps, stronger partnerships between educational institutions and healthcare providers are indeed essential. Teaching hospitals and colleges of medicine must work together to design curricula, define competencies, and identify emerging workforce needs. Clinical training should expose students to full spectrum of healthcare delivery, including primary healthcare, rural health, public health practice, and community engagements, which I think is ongoing. Such exposure will enable future professionals to develop a deeper understanding of the health needs of the populations they serve. The third pillar in this relationship is public policy. Perhaps this is where I belong. Policy serves as a bridge that connects education and practice. It creates the enabling environment within which healthcare professionals are trained, employed, and retained. Effective policies influence workforce planning, financing, regulation, accreditation, and professional development. Good policies, more than regulate, it anticipates future challenges. It aligns national priorities with available resources and creates an environment in which innovation can actually flourish. Health policy should therefore be proactive rather than reactive. Health policy should be evidence-informed rather than opinion-driven. Health policy should be people-centered rather than institution-centered. One of the most important policy challenges facing Nigeria today is workforce planning. Building a resilient healthcare workforce requires accurate forecasting of future needs. We must understand how many doctors, how many nurses, how many pharmacists, how many specialists we will require over the next decade. We must identify where these professionals will be needed and what skills they must possess. Workforce planning must be driven by evidence rather than assumptions. Another critical policy issue is workforce retention, which the Vice Chancellor actually spoke about earlier on. The migration of healthcare professionals has become a major concern across many developing countries, including our own country, Nigeria. Our health professionals are highly sought after globally because of the quality of their training, and indeed our resilience and our natural commitment to every service we find ourselves. While migration is a legitimate individual choice and part of an increasingly interconnected world, its impact on national healthcare capacity cannot be ignored. It is important that our national conversation on health workforce migration remains balanced and evidence-informed. The mobility of highly skilled professionals is an established feature of the global knowledge economy. Indeed, the international demand for Nigerian health professionals is itself testimony to the quality of medical education and professional training within our institutions, thanks to our professors. The challenge, therefore, is not migration per se, but unmanaged migration that undermines domestic health resilience. This challenge is not unique to Nigeria. According to the World Health Organization, the world currently has more than 70 million health workers, yet a projected global shortage of approximately 11 million health workers is still expected by the year 2030. And I guess Nigeria will take a large percentage of that, with the greatest deficit occurring in low and middle income countries, particularly in Africa. The implications, therefore, are profound. As wealthier countries seek to address their own workforce shortages, competition for healthcare talent will intensify. Mark my words. Countries such as the United Kingdom, Canada, Australia, and the United States continue to recruit health professionals from developing countries, including our own country, Nigeria. The result is a global marketplace for talent in which nations that fail to invest strategically in their workforce risk losing some of their best trained professionals. This reality demands a deliberate and coordinated national response. Our response should therefore move beyond the traditional narrative of brain drain towards a more constructive framework of brain circulation and brain gain. Nigerian professionals in the diaspora constitute a remarkable reservoir of expertise, innovation, research capacity, and investment potentials. Through structured academic partnerships, visiting professorship, tele-mentoring, collaborative research, digital specialist clinics, and temporary return programs, the diaspora can become a strategic partner in strengthening domestic health system. The solution does not only lie in restricting movements. Rather, it lies in creating an environment in which healthcare professionals can actually thrive. Competitive remuneration, I repeat, competitive remuneration, conducive working environments, I'm iterating this, opportunities for career progression, access to continued professional development, and recognition of professional contributions all contribute to retention. People are more likely to remain where they feel valued, where they feel supported, and where they feel empowered to achieve their full potential. The issue of resilience also deserves particular attention. A resilient healthcare workforce is not simply one that exists in sufficient numbers. It is one that can adapt to change, respond effectively during emergencies, and maintain essential services during periods of crisis. Resilience encompasses technical competence, psychological well-being, institutional support, and organizational adaptability. Building resilience, therefore, requires investment in both individuals and systems. Healthcare workers must have access to continuous learning opportunities that enable them to acquire new skills and adapt to changing circumstances. Institutions must cultivate supportive workplace cultures that promote well-being and prevent burnout. Policymakers must ensure that healthcare systems possess the resources necessary to withstand future shocks and disruptions. Research and innovation have an equally important role to play in this endeavor. Universities, colleges of medicine are centers of knowledge generation and intellectual leadership. The research conducted within these institutions should contribute directly to solving the practical challenges facing our healthcare systems. Questions relating to workforce retention, rural healthcare delivery, digital health adoption, and service quality requires evidence-based solutions. Policymakers must actively engage with researchers to ensure that public policy is informed by sound scientific evidence. As we look towards the future, technology presents both opportunities and challenges. Artificial intelligence, digital health platforms, and telemedicine are already reshaping healthcare delivery worldwide. However, technology cannot replace the human element that lies at the heart of medicine. Compassion, empathy, ethical judgment, and professional integrity remain uniquely human attributes that will continue to define excellent healthcare worldwide. For Nigeria, digital innovation also presents an opportunity to leapfrog traditional constraints. Telemedicine, electronic health records, mobile health technologies, remote diagnostics, and digital learning platforms can significantly improve access to quality healthcare in underserved communities while strengthening workforce productivity. Harnessing these opportunities will require strategic investment in digital infrastructure, regulatory frameworks, and workforce capacity development. Ladies and gentlemen, let's focus on President Tinubu's health sector renewal agenda. As a government official, you should not expect that I'll just come and talk theory. I must talk about President Bola Ahmed Tinubu. It is therefore encouraging that under the leadership of President Bola Ahmed Tinubu, health sector reform has been elevated to a strategic national priority. You know, this is my opinion. You may disagree with me. In December 2023, the President launched the Health Sector Renewal Investment Initiative and the Presidential Health Sector Renewal Compact, which is a comprehensive framework designed to transform Nigeria's health system and accelerate progress towards universal health coverage. The initiative recognizes that no health reform can succeed without investing in the healthcare workforce. The significance of this initiative lies not merely in the articulation of policy objectives, but in its recognition that sustainable health sector reforms requires an integrated systems approach. The compact acknowledges that health outcomes are influenced not only by healthcare financing or infrastructure, but also by governance, workforce development, digital transformation, community engagement, and institutional accountability. In many respects, it reflects contemporary global thinking on health systems strengthening, which aligns with the World Health Organization vision for resilient, people-centered health systems. The reform agenda focuses on strengthening primary health care, improving health outcomes, expanding access to quality services, enhancing healthcare financing, digitizing health systems, and importantly, developing, managing, and retaining the health workforce. Recent reports from the Federal Ministry of Health and Social Welfare indicate that substantial progress has been made in implementing the key performance indicators of the Presidential Health Sector Renewal Compact, which is reflecting the government's commitment to accountability, performance, and measurable outcomes. As policymakers and healthcare leaders, we must ensure that our educational institutions align their programs with the objectives of these national reform agenda. The success of these reforms will depend largely on the availability of competent, motivated, and future-ready health professionals that I'm seeing before us today. The health sector renewal agenda, therefore, provides more than a policy framework. It offers a unique opportunity to redefine the relationship between education, service delivery, and public policy. If implemented with fidelity, transparency, and sustainable stakeholder engagement, as we're having today, it has the potential to position Nigeria as a continental leader in health systems, innovation, and workforce development. Next, we look at from training for employment to training for national impact. Historically, medical education has focused on producing clinically competent professionals. While clinical excellence remains indispensable, the healthcare challenges of the 21st century requires a broader perspective. This is a reality. The future doctor must therefore understand the health systems, not just clinical medicine. The future nurse must appreciate public policy. The future pharmacist must embrace digital health technologies. The future public health practitioner must be comfortable using data analytics and artificial intelligence to inform decision making. In other words, our educational institutions must move beyond training for employment and begin training for impact. The healthcare workforce of the future must be capable of leading multidisciplinary teams, responding to public health emergencies, implementing innovative solutions, and contributing to health policy development. The traditional separation between academia, the healthcare practice, and government policy is no longer sustainable. The future belongs to professionals who can operate effectively across these boundaries. And that is why I decided to come to Benin to share my thoughts with you. At this juncture, Rita asked me to share practical experiences with you. Therefore, these are some of my practical experiences as a public service officer. From my years in public service, one of the recurring observations in health sector administration is that policy often fails, not because the policy itself is flawed, but because the workforce implications were not adequately considered during its design. The policy may be technically sound, funding may even be available, infrastructure may be provided, yet implementation falters because there are insufficient personnel to operationalize the intervention. Over the years, I have come to appreciate a simple but profound truth. In public administration, implementation is a true test of policy. A beautifully written policy document may inspire confidence, but unless translated into measurable improvements in the lives of citizens, it remains merely an expression of good intentions. The true measure of governance is therefore not the quality of policy formulation, but the effectiveness of policy implementation. Implementation succeeds when institutions possess the leadership, possess the human resources, have the financing, the governance system, and organizational culture that is required to transform policy into real action. Conversely, where these enabling factors are absent, which often happens in our country, even the most ambitious reforms struggle to achieve their intended outcomes. I have witnessed personally situations where health systems were constructed health facilities were constructed faster than qualified staff could be recruited and deployed. I have seen instances where sophisticated medical equipment remain underutilized or even remain in the containers because adequately trained personnel were unavailable to install or to utilize, or even the place to install them were not even ready. I have observed programs with enormous potential struggle because workforce planning was treated as an afterthought rather than a foundational component. These experiences underscores a simple but powerful lesson, which is health workforce planning must be integrated into every stage of policy formulation and implementation. The success of health policy ultimately depends on the people responsible for translating policy into action, which is everybody seated here. Let me again share another practical example, the oncology lesson. Building systems, not just facilities. This again is my personal experience. Allow me to draw an example from Cancer Center, an area of growing importance across Nigeria. Though I'm an ophthalmologist, but I've piqued a lot of interest in oncology. Building an oncology center is not merely about constructing the bunkers or acquiring sophisticated equipment like the MRI, the LINAC, the CT simulators, the PET CTs, the brachy machines, the cyclotron, and many more. A truly functional cancer center requires an ecosystem of highly trained professionals, including oncologists, oncology nurses, medical physicists, radiographers, pathologists, pharmacists, technologists, counselors, and palliative care specialists. Medical doctors or oncologists alone do not represent a functional oncology center. Without the workforce, the infrastructure cannot deliver any impact. The oncology example also reminds us that investment in healthcare should be conceived as investments in integrated ecosystem rather than isolated projects. The lesson applies equally to every aspect of healthcare. Whether we are discussing primary healthcare, maternal health, mental health, emergency care, or specialized tertiary care, sustainable success depends on building systems that develop and support the people who provide care. Infrastructure is important. Technology is important. Financing is important. But people remain the most valuable resource in healthcare. Now let's look at the way forward. A new social compact. As we look towards 2030 and beyond, I believe Nigeria requires a new social compact with health workforce development. This compact must bring together government, universities, teaching hospitals, professional associations. Thanks, NMA chairman is here today. The private sector and the development partners around a shared vision. And I think the conversation today is providing such a platform. It must prioritize evidence-based workforce planning. It must strengthen the linkage between medical education and health service delivery. It must invest in faculty development and research. It must improve working conditions and career progression. And it must create an environment in which our brightest minds see Nigeria not merely as a place where they were trained, but as a place where we can build fulfilling and impactful careers. If we succeed in aligning medical education, aligning health systems, and aligning policy, Nigeria will not only produce more health professionals, we will produce the leaders, the innovators, and change makers who will drive the transformation of healthcare across Africa and the world at large. As I draw conclusion, Rita asked me to speak for 35 to 40 minutes, and I think I'm at about 30 minutes now. To my students gathered here today, as a former student union leader, great Uniben, allow me to say that you are entering the profession at a transformative moment in history. The healthcare landscape you will inherit will differ significantly from that of previous generations. Yet, the fundamental mission of medicine remains unchanged. That is to alleviate suffering, promote health, and serve humanity. The future will require not only technical excellence, but also leadership, innovation, and a commitment to lifelong learning. Nigeria's aspiration to achieve universal health coverage and improve health outcomes cannot be realized without a strong and resilient healthcare workforce, which you belong. This objective requires collective action. Now, government alone cannot achieve it. Universities cannot achieve it in isolation. Healthcare institutions like UBTH cannot achieve it independently. Success will require genuine partnership amongst all of us seated here. The theme of this lecture reminds us that collaboration is not merely desirable, it is indispensable. When medical education is aligned with healthcare delivery needs, graduates will become more effective practitioners. When health systems support professional development, healthcare workers become more productive and fulfilled. When policy provides strategic direction and adequate resources, institutions are empowered to succeed. When all three elements above function in harmony, transformative change becomes very, very possible. I envision a future in which every Nigerian community has access to competent healthcare professionals, where our colleges of medicine are recognized globally for excellence, where teaching hospitals serve as centers of innovation and research, where healthcare workers are motivated, supported, and retained, no more Japa syndrome, and where public policy consistently reflects evidence and national priorities. This vision, though ambitious, but it is achievable if we commit ourselves to collaboration and shared responsibility. Vice Chancellor, Provost College of Medicine, management of the University of Benin, as I conclude, ladies and gentlemen, let me emphasize that the healthcare workforce is the backbone of every health system, and medical education provides the foundation. Health system provides the platform, and policy provides the direction. When these three pillars are aligned, transformation becomes possible. When they operate in silos, like the theme of this workshop, progress remains limited. The future, therefore, belongs to institutions and leaders willing to collaborate across traditional boundaries. Let us commit ourselves to building bridges between academia, practice, and policy. Somehow I belong to all three. Let us produce graduates who are prepared for the future. Let us create health systems that support excellence. Let us enact policies that sustain talent. And together, let us build a resilient healthcare workforce capable of delivering quality healthcare to every Nigerian, whether rural or any other location in the country. Permit me to leave you with the words of the distinguished physician, educator, and humanitarian, Sir William Osler, who observed that the good physician treats the disease. The great physician treats the patient who has the disease. We want you to be the great physicians. In our own time, we might respectfully extend that timeless wisdom by saying, and I quote, that the truly great health leader builds a system that enables healthcare professionals to care for every patient with excellence. Let us therefore work together, ladies and gentlemen, as educators, as healthcare providers, as researchers, professional bodies, and policymakers to create a healthcare system capable of meeting the needs of patients, present, and future generations. The journey towards a resilient healthcare workforce is a long one. We must therefore go together. As I close, Vice Chancellor, sir, management of the great University of Benin, I want to once again thank you for giving me the opportunity to speak with you, as I'm also here to learn from your comments and contributions. God bless you all. God bless the great University of Benin. God bless the Federal Republic.
Ladies and gentlemen, you would agree with me that Dr. Ibrahim Abubakar Kana, MNI, has done very well with this lecture. Please, let's put our hands together again for him. I will now invite the Vice Chancellor, Professor Edoba Omoyege, represented here at this scientific conference by Professor Christopher Osubo, our Deputy Vice Chancellor, Administration, to present our keynote speaker with a plaque. Please, this presentation should be supported with the presence of the CWC's chair, Professor Rita Momo, Provost, College of Medical Sciences, represented by Deputy Provost, Professor Vivian Omwemo, as this presentation is made. Professor Andrew Obi, please can we have the plaque?
On behalf of the College of Medical Sciences, University of Benin, I'd like to present this plaque for an impactful lecture. In fact, if I call you a professor, I'm not mistaken, because this is excellent. I mean, I was just looking at the slides. It was wonderful. So, on behalf of the Vice Chancellor, who is not here but has asked me to represent him, I'd like to present this plaque to Dr. Ibrahim Abubakar Kana, MNI, on this occasion where you presented the keynote lecture. So in recognition of your distinguished contribution, I present this to you. Congratulations, sir.
After this session of photograph, we'd like to have everyone here now. Please, Vice Chancellor, sir, kindly remember where you are. We'd like everyone on the high table to please join. We'll quickly, management staff, please rise up to join the Vice Chancellor.
Principal officers.
For another session of photograph. Our videographers, please, can you just hold on a minute? The Deputy Vice Chancellor Administration is right here. Our registrar, here represented, is right here. The university bursar is right here. The university librarian is also here. We have, these are the compliments of the management staff of the university taking this group photograph with our keynote speaker today. Okay, we now invite other dignitaries on the other side of on the other table. Please come join, where we have the deans of the school, of the College of Medical Sciences. Please come, where we have the provost, College of Medical Sciences, Benson Idahosa University, Professor Momo. And also, we're inviting here
Principal officers of the college,
Professor Ehigieba. Please join management taking this photograph. Thank you. Thank you. Thank you, DBC Akkad, for making room for him. Thank you. Thank you very much, ladies and gentlemen. We appreciate you. We're grateful.
All right, we're going to have some more acknowledgement. We want to thank the Vice Chancellor and his team, ably represented by DVC Admin Professor Christopher Usubo. We appreciate you and the team from the all members of principal officers of the university. Thank you all so much. We're going to make some more acknowledgements as we bring this first session to a close and go into the tea break. But we are going to have goodwill messages from the Nigerian Medical Association, from NAMDA, from MedSabam, and from MDCAN. Please, I need them to prepare in that order. The Nigerian Medical Association, MedSabam, NAMDA, and MDCAN.
We'd like to crave your indulgence, so please make the goodwill messages as short as possible. Thank you, so that we can accommodate every one of you.
All right, so let's welcome the representative of the Chairman of the Nigerian Medical Association Edo State in his able capacity as the Deputy Chairman, Nigerian Medical Association Edo State, Dr. Oduware Ehigegba. You're welcome, sir, for your goodwill message from the Nigerian Medical Association Edo State.
The Nigerian Medical Association Edo State, goodwill message to be taken by Dr. Oduware Ehigegba.
Thank you, sir. Dr. Oduware, you can go ahead, sir. Thank you. Pictures can run simultaneously.
Good morning. Standing on the existing protocol. Good morning, ladies and gentlemen. I'm here representing the chairman of the Nigerian Medical Association, Edo State, Dr. Andre Egbedion, who is unavoidably absent. He's currently in Abuja for the National Executive Council meeting. He sent his good wishes today. I will read his speech as it is with great pleasure and a deep sense of responsibility that I join you today at this very important conference of the College of Medical Sciences, University of Benin. I sincerely commend the organizers for choosing the timely and thought-provoking theme, Breaking Silos, Strengthening Education and Health Systems Through Collaboration. This is more than just a conference theme. It is a call to action. The challenges confronting medical education and healthcare delivery are increasingly complex and interconnected. Medical education affects healthcare delivery. Healthcare challenges should inform medical education. Research should influence policy. Policy should improve practice. And the clinical experience should generate new research questions. We must therefore move from working beside one another to working with one another. At the heart of all our collaborations must be the patient. The patient must not care whether a problem belongs to medicine, surgery, nursing, pharmacy, laboratory medicine, radiology, public health, or government. The patient simply wants timely, affordable, safe, effective, compassionate healthcare. Modern healthcare is therefore fundamentally multidisciplinary, and we must train our professionals to understand that collaboration is not a threat to professional identity. Rather, it enhances professional effectiveness. As the Nigerian Medical Association Edo State branch, we recognize that our responsibility goes beyond advocacy for doctors. We must contribute to building a stronger healthcare system for Edo State and Nigeria. The NMA must serve as a bridge between medical profession, academia, government, healthcare institutions, and the communities that we serve. We are therefore committed to strengthening partnerships in medical education, continuing professional development, research, public health advocacy, medical outreaches, manpower development, technical exchanges, and healthcare system strengthening. We must also confront the challenge of healthcare manpower. Nigeria cannot build a strong healthcare system while losing significant numbers of its trained healthcare professionals. This is a call to action. As we gather here today, we must move beyond identifying problems to creating practical solutions. And I propose that we pursue 5 key areas. Establish stronger and structured partnerships between universities, teaching hospitals, government health agencies. Promote interprofessional education and teamwork. Develop stronger research to policy pathways. Strengthen the connection between medical education and the realities of primary, secondary, and tertiary healthcare. And finally, develop measurable collaborative projects with clear responsibilities. At the end of this conference, let us not leave merely with photographs, certificates, and memories. Let us live with partnerships, commitments, and measurable actions. I commend the College of Medical Sciences, University of Benin, University of Benin, for convening this important conference, and I reaffirm the commitment of the Nigerian Medical Association Edo State branch to working with the university and all stakeholders to strengthen medical education, research, and healthcare delivery. Thank you for your kind attention. Long live the University of Benin. Long live the College of Medical Sciences. Long live the Nigerian Medical Association. Long live Edo State. And long live the Federal Republic of Nigeria.
Thank you very much, sir. Dr. Oduwari Ehigegba, the Deputy Chairman, NMA Edo State, representing the Chairman, NMA Edo State. Thank you so much. I'm going to bring up very quickly, we have in our midst the Honorable Commissioner for Education, Edo State, Dr. Washington Osifo. We want to bring you up to the high table, sir, please. Please, want to bring you up on the request of the Provost. Thank you, sir. Please, let's put our hands together for the Honorable Commissioner for Education, Edo State, brand new Commissioner, Dr. Washington Osifo. You're welcome, sir. To take the next goodwill message very quickly is our chair at NAMDA, Professor Alphonsus Isara. Let's put our hands together for him. After Professor Isara, we'll go to Dr. John Anoye from MedSabam, and then we'll have MD Khan chair. You're welcome, sir.
Thank you very much. I want to stand on the already well-established protocol. I greet you all and welcome you to this wonderful conference, especially from NAMDA. Of course, we can as well say NAMDA is the second host of this conference because all the members, the chairman of the local organizing committee is a member of NAMDA. So we congratulate the provost. This conference is now very consistent, and that is the way to go. And each year we have the conference is an improvement over the previous conference. Congratulations to the provost, Professor Sado, even though he's not here, the deputy provost is here. And I thank all of you who have found time to come and grace this occasion. It can always be better. We continue to support the college in whatever way we can as NAMDA, and we wish you a very fruitful deliberation for today and tomorrow. And at the end, the communique that will come out, we should try to action the communique so that we can translate from research to implementation, and which is the general focus of this conference. Once again, I welcome you. Greetings from NAMDA, and thank you very much.
NAMDA, for those that don't know, Nigerian Association of Medical and Dental Academics. Let's put our hands together for Professor Alphonsus Isara one more time as we welcome Dr. John Anoye, National President, MedSabam, to give his goodwill message. He is also the chairman of Medsabam's Uniben. Let's put our hands together to receive Dr. John Anyoye.
Good morning, everyone. I also will stand on the already established protocol. Medsabam is Medical and Dental Specialists Association in Basic Medical Sciences. That is the doctors in the basic medical sciences. Sometimes because we have BSc programs in the basic medical sciences, people forget that the original persons, all our books were all doctors, and that is what it is. The other name we call ourselves is ASMEDA, which is Association of Specialists, Medical Doctors and Academics. We see this collaboration thing as very timely because whether we like it or not, both the BSc people and the doctors in the basic medical sciences are the foundations of medicine. And a lot of things we will prefer is to see from the bench to the bedside. A lot of research we do in the basic medical sciences, we will need to see them applied in the bedside with patients. The patient is the center. It's supposed to be the center. But in Africa here, we do not somehow believe in ourselves. China and other countries are doing research, and they are going to even the common drugs we have their origins even in plants. Some good research we have on ground can actually be applied to our patients. But we need to bridge that gap. We need to get more medical doctors to come in to see what the scientists are doing at that base and see how we can upgrade such things upwards. This conference, like my chairman just said, Professor Sarah is my chairman because I'm also a member of NABDA in Uniben, and I'm his secretary. And being a national president, I am supposed to be at Abuja already for the NAB NEC meeting. But of course, today is for medical outreach, courtesy visits. So I've tried to say, I want to attend this conference because I'll give an invitation for it first and go tomorrow morning. So my flight is for tomorrow morning because I'm a member of the National Executive Council of NMA, and I will meet my NMA chairman there because we need to support and encourage this program that has remained for the past years, and will commend the executive and also Professor, let me call him Professor Kana because if I don't, I've seen him several in NMA national functions, and he speaks like a professor actually. So it's just that he's not here, and we have interacted so much. We thank you all for coming. We thank the students, and we thank the college. Thank you.
Thank you very much, sir. Dr. John Anyoye, National President, Medsabam. We want to welcome very quickly to the high table the Permanent Secretary, Ministry of Health, Edo State, Dr. Paul Egbemerio, MNI. Please, sir, you want to join us at the high table? Permanent Secretary, Ministry of Health, Edo State, Dr. Paul Egbemerio, MNI. Please, sir, join us on the high table. Final one, yes. Consultant Dermatologist, MD Khan Chair, UBTH, Dr. Benson Okwara. Thank you, sir.
Okay, thank you very much. Distinguished guests present, I must recognize the Vice Chancellor, the Provost of the College, Principal Officers of the College, professors here present, and all invited guests. Breaking the silos requires collaboration, and the keynote speaker did great justice to this topic. In fact, I was enamored by his slides, how colorful, and just kept one's attention to it. I must congratulate the local organizing committee led by Professor Rita Momo for putting together this amazing, amazing conference. I want to wish you all a very successful deliberation in this conference. Today's process so far has been wonderful and amazing. And I must always say that the patient, the people will always be at the center
of it all. You can have all of the education that you have, but the patient is the center of it all. So whatever it is, all the collaboration that we should talk about here should focus on getting the people better in terms of healthcare. So I want to congratulate the conveners of this conference, and I wish you a very successful deliberation. This is from Medical and Dental Consultants Association of Nigeria, UBTH chapter. Thank you very much.
Thank you very much, Chair, MD-CAN, UBTH, Dr. Benson Okwara. The final one before we go on tea break will come from none other but the Provost, College of Medical Sciences, Benson Idahosa University, a former Commissioner of Health at Edo State, former Dean School of Medicine, UNIBEN, one time this, one time that. Professor Moses Momo for the final good message, and then we'll go on tea break.
The Vice Chancellor, University of Benin, our guest speaker, Dr. Ibrahim Kana, my very distinguished retirees, distinguished ladies and gentlemen, mine is just to acknowledge and thank the guest speaker and congratulate him for a very, very brilliant lecture. As he set out, I took my pen to write down areas I thought I would disagree with him, or areas that I thought I would modify. But all through the lecture, from the beginning to the end, I was in agreement with all that he said. AI, he made the right point that the human element of the clinician is still very, very important. The best part of health policy is the implementation. He made the point very strongly by citing personal experiences where equipment had been procured and they are still in their crates because there was no provision for technical expertise on their installation or their use. So I want to congratulate you, Dr. Kana, and congratulate the Vice Chancellor, the Provost, and the team led by my wife who identified you to come and give this lecture. At the beginning, for those of us who are here at exactly 10 a.m. or before 10 a.m., when I looked and I didn't see the medical students, I was a bit worried. I asked the three deans of the college, where are your students? This is the type of lecture they should listen to. This is the lecturer that they will listen to, and they will model their careers and lives after the lecturer. I'm sure you all agree with me today. I didn't know that he was a medical student activist. I didn't know that before now. But you could see that he was a full student, good clinical student, participated in social activities, was even a student leader of medical students, came all the way from Zaria to talk here as a medical student and as a resident doctor. And yet, he has attained these dizzying heights in both clinical practice as well as public administration. So we are doubly blessed today that we have a lecturer who I believe the students who have listened to him have somebody to model their lives after, their careers after. So once more, I thank you and congratulate you for this outstanding performance. God bless you.
Thank you very much, sir. Professor Moses Momo, Provost, College of Medical Sciences, Benson Idahosa University. And like he said already, he's the husband of Professor Rita Momo, the chair of the LOC. I also want to acknowledge here present with us the Acting Dean, Faculty of Basic Clinical Sciences, Benson Idahosa University, Dr. Harrison Egbo. Dr. Harrison Egbo, still with us. We acknowledge you, sir. A few more acknowledgements. Please, the tea break is already on, like I've been informed, so we may not need to step out. So I guess tea, whatever tea constitutes, has gotten to you. I will make the following recognitions before we proceed into the next session. I want to acknowledge our teachers and trainers here present from the Department of ENT, Head and Neck Surgery, Professor Ngozi Onyegwara. Let's put our hands together for her. Reverend Sister Professor Ngozi Onyegwara. We have from Clinical Pharmacology and Therapeutics, Professor Abimbola Okpadeyi. We have from the Department of Anatomy, Professor Freddy Agoreyo, a former Dean of Basic Medical Sciences. We have from Oral Pathology and Medicine, Uniben UBTH, Professor Messi Oko. We also have from Oral Pathology, Professor Dr. Dixon Oko. We have the Head of Department, ENT, Head and Neck Surgery, Professor Brother PROC Adobame. You're welcome, sir. We have Professor Gerald Forai, former Deputy Provost, College of Medical Sciences. We have Professor O.F. Ehigiamusoe, HOD, Radiology Department, Uniben UBTH. We have Dr. Osasu Ogumbo, Radiology Department, UBTH. We have Dr. Philip Ogodi, Associate Professor, Pediatric Dentistry, Uniben, and Consultant Pediodontist, UBTH. Please keep your hands clapping, thank you. We have Professor Fidelis Olumese from the Department of Medical Biochemistry. He's one of our resource persons for this event. We have Dr. Oge Ehondo. We have Professor Magdalene Odumvo, HOD Child Health. We have Professor Andrew Edo, Internal Medicine. We have Professor Sonny Okegbeme, HOD Community Dentistry. We have Professor Vivian Usagona, Professor of Ophthalmology, Uniben. We have Dr. Dalintes Oronsaye, Department of Ophthalmology, UBTH. We have Professor O.T. Edema, Professor of Ophthalmology, Uniben, UBTH. We've introduced already earlier, but we'll give her the honors for a second time. Former DVC Administration, Uniben, Professor Catherine Ukpoa, Professor of Ophthalmology, Uniben, UBTH. We have Dr. Harrison Omokwa, HOD Restorative Dentistry, past Dr. Harrison Omokwa, HOD Restorative Dentistry, past National Financial Secretary, NMA National, past Chairman, Edo, NMA. We also have his wife with us, Dr. Mrs. Gabriela Omokwa, Consultant Senior Lecturer, Medical Microbiology, Uniben, UBTH. We have also with us Hospital Consultant from Department of Family Medicine, UBTH, Dr. Egareva Elizabeth. You're welcome, ma. We have from the Department of Chemical Pathology, School of Basic Clinical Sciences, Aikoroge Orobosa, PhD. We have the HOD of Obstetrics and Gynecology, Uniben, Professor Egiga Enabudoso. You are all welcome. I see many faces around and I want to welcome them specially. Please permit me, I'm just working with the list that is available to me, but just to also acknowledge former CMAC, UBTH, former head of Department of Surgery, Professor Stanley Okubo. He's going to be one of the moderators for the next session that is kicking off really shortly. So we're going to be moving into a panel session very shortly. We just have a musical interlude before we begin on the panel session in a minute. Thank you. We have a 5 minutes break. You can just stretch out your legs if you want to move around before we go into the plenary. Alright, so we're going to have the plenary session commence in a bit, and we're going to call the moderators and the panelists off stage in a few minutes.
Plenary session for this 4th scientific conference has begun. Please we crave the indulgence of the moderators of the sessions. Please come off stage. Kindly come off stage now. Please come off stage, moderators.
So we have for the panel session Professor F. Amadi. If Professor Amadi is around, please let's bring him up on stage.
Professor Amadi, please come off stage.
As one of our speakers. Professor Amadi is speaking physically. We have Professor Michael Okorie who's going to join us virtually.
Professor Michael Okorie.
And then our moderators are Professor Omokwa Adeleye and Professor Stanley Okubo. Professor Omokwa Adeleye and Professor Stanley Okubo, please join us.
Please kindly minimize the movement across stage only for the panelists and the moderators on stage, please. Let us minimize the movement across the stage.
Professor Omokwa Adeleye, you're welcome, sir. And Professor Stanley Okubo are moderating this panel session.
Professor Amadi, we welcome you. Thank you.
The team or the sub-team of this session is the role of AI and digital technology in transforming medical education and health systems in the medical sciences. I assure you it's going to be an interesting conversation. Professor Stanley Okubo to join the panel upstage. Professor Stanley Okubo, sir, to join the panel upstage. Professor Mokwa Adeleye will be chairing this session alongside Professor Stanley Okubo, and our speakers are Professor Amadi, Professor Frank Amadi, and Professor Michael Okorie. Professor Michael Okorie is joining us virtually. Professor Frank Amadi is here with us physically. So once Professor Okubo joins us, we're ready to start. If you're outside, please come inside. We're ready to start the plenary session. If you're outside, please come inside. We're ready to start the plenary session. Thank you. The topic for our first plenary session is the role of AI and digital technology in transforming medical education and health systems in the medical sciences. We all know that we are in the age of artificial intelligence. AI is used to do anything you can think about. You just have to let AI know what exactly you want it to know, and it produces results. So we're going to have that conversation. As has been introduced already, our chair and co-chair, who are the moderators for this session, is Professor Omokwa Adeleye and Professor Stanley Okugbo. Let's put our hands together for them. Professor Omokwa Adeleye and Professor Stanley Okugbo.
All right, thank you very much, our moderator. And I want to thank the chair of the organizing committee for inviting us. We also especially thank our speaker or our panelists here who's going to be addressing us, including the panelists we're expecting from outside the country who will join us virtually. Artificial intelligence has become the emerging reality of our times. Medical education and health systems must benefit from the emerging technology so that the reality that's before us in everyday life then takes advantage of the opportunity to grow itself, and vice versa, having medical education and health systems also benefiting from the emerging technology. So it's a vicious cycle. For AI and digital technology to grow, you need health systems and medical education. So we need, therefore, to see our role as not only developing health systems and medical education, but contributing to the proper development of technology. We have a duty to do so. It's moral, it's expected, but at the end of the day, our focus, our primary interest here is to add value to medical education and health systems as a part of the bigger picture of collaboration, which is the key word in this program. So I'm going to hand over right away to Professor Stanley Okugbo, who is going to launch us further into this discussion and hand us over to our panelists for questioning. Thank you very much.
Yeah, good afternoon, sir. Good afternoon, everybody. You're welcome to this plenary. Today we're going to be delving into something that is very topical, and I'm sure something that all of us will want to hear more about, and so that we can have some enriching interactions and some directions, because this is an emerging field for us in medicine and in this part of the world. We all know that we do need system strengthening in terms of our healthcare space and in terms of how we do our educational programs. AI is very disruptive, and we want to see how that disruptiveness can be used to enhance our services, our research, and every other thing that we are engaged with. This afternoon we have with us two very brilliant persons who are going to be speaking with us. We have with us on site Professor J. Ahmadine. He will be breaking the ground and speaking to us just to introduce this subject. We also have somebody who will be speaking to us from the diaspora, Professor Okorie. So we are waiting for the ICT people to tell us that he's online, and we can get him online. But what I want you to do now is to get your pen and papers or get your notepads in your digital devices and begin to note some of the things that are going to be said, so that we can have a very rich and exciting session this afternoon. So I'll just quickly call on Professor J. Ahmadine. Professor, please. F. Ahmadine, sorry. Yeah, you're right, F. Ahmadine, to just quickly delve into it. Thank you. Yes, go ahead. Yeah, go ahead. Please, he said he has a slide. Can we just project it immediately, quickly, just to make it fast for him? You can use the project. That'll be fine.
Good afternoon, ladies and gentlemen. Please permit me to stand on the already established protocol in order to save our time. Oh, thank you, ICT. The slides up. So today, in line with the theme of the conference, I'll be speaking on AI and digital tools application in medical education and healthcare. I'm Professor Frank Amadin of the Faculty of Computing. So if I'm not getting your medical terminologies right, just know that I'm a programmer. Thank you very much. Next slide. So artificial intelligence and digital technologies are changing the way that knowledge is created, delivered, assessed, and applied across different sectors of the economy. The important concept there is that knowledge is created. When it is created, it needs us to be applied. We are currently in the medical conference, but when we look at AI and digital technologies, it's not restricted to any sector. In fact, it cuts across every sphere of human life as it is today. So medicine and medical education is among the field experiencing this transformation. Now, AI provides capabilities for learning from data, recognizing patterns, generating content, supporting predictions, and assisting decision making. Most of the time, users of AI seem to take AI out of context. AI is simply not a magician, it's a servant. We'll get to see that shortly. AI is a servant, and it depends on the way you use it, whether responsibly or irresponsibly, before you know what AI can actually do for you. Now, digital tools, they provide the platform and technology through which information, communication, learning, and health services can be delivered. Good. Every day, medical professionals, they know this very well. When you interact with your patients, most of the time you go to the clinic, and you see that the medical practitioner attending to you takes the pen and paper and is taking note of some things. Basically, what they are getting from you is data. Data useful to advise in your medical treatment. So these data, we categorize them as the patient histories, laboratory results, medical images. They are used for research publications and then clinical guidelines. These items are the core of AI development. Outside the models, outside the technology, data is the new oil in AI, in computing. So you know, most of us that have our gadgets with us, our digital tools, our phones are with us everywhere. We put information there on a daily basis. These are data being harnessed and may be used for whatever purpose. Now the challenge is no longer how to access this information, but turning the information into useful knowledge. Like I did say earlier, that knowledge has to be what? Created. Now what exactly is AI? What exactly is artificial intelligence? Artificial intelligence is very simple. The ability of the computer system to perform tasks that are normally required aspects of human intelligence. That is AI for you. So when you say AI is doing this, AI is doing this, know that the human intelligence has already done it. Because the computer system cannot think, cannot reason, computer system does not have intelligence. So we bring in a form of intelligence into it, hence the word artificial. And the humans have what? Biological. So that is the distinctive factor. The human intelligence is the original intelligence. So the AI cannot know more than what the human know. It may know more than you at a particular level, but there is a human somewhere that already knows what this AI knows. And that's where we harvest information. Once we're able to get the knowledge of that practitioner, AI seems to become intelligent to that level. So please, let's get that very correct and don't allow AI to threaten you. I keep telling persons that don't fear AI. What you should fear is the computer system itself, not the AI. It's what the computer will do with the knowledge given to it that is the crux of the issue, not AI itself. AI, if I tell an AI-enabled device that will come into the auditorium from the roof, it will never walk in through the door because that is the level of intelligence it has. It's artificial. But if you tell the AI correct information, it will act correctly. Now, it enables the computer system to learn from data, recognize patterns, understand the language, interpret images, predict outcomes, generate content. That's what we're having today, generative AIs, and then support decision. One of the strongest points that AI makes use of in its artificial intelligence are sub-contemporary technologies, as shown on our screen. These, you see, most of us just look at the very top. You see artificial intelligence there. And currently, you look at the bottom, you see what? ChatGPT. You see the middle point. How many of you have used these middle items? Machine learning, deep neural networks, learning, transformers, generative AIs. How many of you have used them before? I think maybe 2%. But everybody has used AI, right? Good. Everybody have entered a vehicle before. You've entered a car before. I'm sure only 2% will know what a carburetor is. Maybe a lot will know what a battery is. So the makeup of AI is not just the buzzword AI. It has what? Components that enable it. And these components are clearly listed here. The machine learning is what helps your AI to learn from data. AI learning from data, machine learning. We have the deep learning. The deep learning is a higher level of neural networks. They are networks interconnected. You know the human cell? It has these connections also. That is where the scientists adapted the issue of the neural network from. Then, we have the digital tools. What are digital tools? Your phone today is your chief digital tool. It is the hardware replacing the computer system gradually. In fact, most phones now have become computers to us. Now, outside this hardware, there are what? Software elements. Now, these software elements that run on your phone or your computer system, they are also what? Part of digital tools. And they exist as learning management systems, electronic health records, telemedicine, mobile health applications, and so many. Now, not every digital tool that you have a computer, you have a phone, or you are connected to a health record system, it doesn't translate to AI. So not all digital tools have AI, but AI can be embedded in this digital tool to make them quite powerful. Now, let's look at a health record system. You go there, the doctors, the nurses, the laboratories, they keep pushing data of a patient into the record. But nothing happens. It will take AI to transform this data into meaningful information. Now, some pictures are there. We have the learning management system. We have the electronic health record, the telemedicine. Telemedicine is a very good digital tool today where physicians can now turn to remote consultants. you can consult with your patient remotely by advising on what to do. And UBTH currently operates the smart clinic system, and I think that's quite commendable. Then AI in health care. Okay, Donald Bright. There are a lot of applications today, a lot of applications currently running, even here in Nigeria, that have implemented AI as part of their digital tools. We have the Aisha Chat, the Here Arrow, Cavero, and so many others. These are software applications that currently assist physicians in speaking to their patients and advising medical care. AI in medical education. Like I said, AI is a servant. If we have an experienced medical practitioner and is able to give good information to AI, it will also, I don't want to use the word he because AI is not animate, so permit me to say it will also prescribe correctly and also do exactly as told. Now, AI being used not just in medical education allows for personalized learning, intelligent tutoring, and also collection of good feedbacks. I'll look at some case studies. We have students in our medical college. I'm going to be considering student A and student B. Very quick analogy. Well, we have a student A who is very strong in physiology, but struggles with ECG interpretation. And then we have student B, both in the same class, very good with ECG, but is struggling with pharmacology. And yet they all attend the same class. The instructor, the lecturer will not discover this. Will not discover this, but with artificial intelligence, we are able to personalize, find out the issues with these particular students separately. This can be discovered through test scores. They are giving tests in these areas through question and answer, through interaction. We collect data about them, and then we can advise student A, give student A more exercises on ECG, while student B receive more exercises on pharmacology, thereby improving their areas of deficiency. This is a very key area of AI. Secondly, one of AI's fascinating strength is image recognition. And it is said that what you read, you remember 10% of the time. What you hear, you remember 20% of the time. What you see, you remember 30% of the time. So we took that higher percentage and said image recognition is key to any training. And also, we allowed AI to participate in these activities because what you participate in, you remember 90% of the time. So that's why practice makes perfection. 90% is very important. AI makes use of image and practice to become better. It keeps learning on a daily basis. Whenever AI receives a new element of data, it continues to learn. And that is why it's becoming perfect gradually. And we are the ones that are giving it this strength. A third case study is disease prediction. Patient data. From the very first slide, you saw a physician talking to a patient. And I did say that data about that patient is being recorded. This data is sent to our AI device. It goes through the AI model. You can see some of the data collected from a patient. The AI does not really know what this data is all about. It's going to pick from the experience of the physician. So if a physician that is not well grounded is used to train this AI will tell you it lies. So we rely solely on physicians. In fact, we call them those with domain knowledge. This domain is medical domain, hence the term physician. So any domain that AI is to be applied to, we must get those that are well grounded, seasoned in that particular field. Now, our AI models, we have the artificial neural network, that's the ANN. We have the fuzzy logic, talks about truth, how true or how false, variation. Then we have the genetic algorithm. This is not a technical session, so I won't go too much into it, but I'll just mention the names: machine learning, deep learning, and the convolutional neural network. Then, when these models have worked on the data, then we have our risk prediction. We can now predict, and this prediction is based on events that have occurred over time. If we have an image of someone looking very slim, and we say this person is suffering from sickle cell, anytime AI sees somebody that is quite slim as that, it will conclude this is sickle cell. Meanwhile, this person will be suffering from hunger. So AI is very funny. Now we just prescribe based on what you have told us. So please never blame the AI, blame yourselves for telling us this is what it is. What happens if AI goes wrong? It's very simple. First, I've said don't blame us. Don't blame us that are training it. Blame who? You that is telling me how to train it. Now, when AI goes wrong, it will produce incorrect information, hallucinated references, the references that does not exist. Most of you that have used ChatGPT, if you ask ChatGPT for a particular reference, it will give you a lot of items. Please Google those references. I can assure you that over 50% of them do not exist. It is the truth. So then there are biased outputs, and then inappropriate recommendations. Confidence. You know, AI gives you reports confidently to put some in bold, highlighting them with fancy exclamations and all. Confidence is not the same as correctness. Okay, I still have enough time. Now we have the trust framework. Trust framework. We ask, what do I want AI to help me to accomplish? This is what we call prompt in computing or in use of AI. If you have used AI in any way at all, please come to us in Faculty of Computing. We'll issue a certificate of participation in our program. We'll just look for a degree and give to you, or we'll call it certificate of participation, because you're already making use of our tool and you are training yourself. Now we ask, what do you want the AI to do for you? They will check. This is very critical. We check, is its output believable? How do we check this? The professionals must come and check for us. Then we verify. Can I confirm it using authoritative evidence? Someone is very slim. AI says he's suffering from sickle cell. Meanwhile, the physician have seen that this is lack of vitamin, lack of protein, lack of carbohydrates, in fact, hunger. So we need to verify using authoritative evidence. Then we need to judge. Does it make sense? What I've just heard from AI, does it make sense? You don't just jump into using it. Whenever if you get information from AI, input that information again into that particular platform you are using. It will tell you, this is okay but not strong enough. Why? Because it keeps correcting itself with new information. Then we'll now decide to accept it or to reject it. The bottom line is that AI's output requires human judgment before responsible action is taken. In our Nigerian context, AI for our problems with our data for our people. I'm glad that the director of AI is here. Prof is the director of Center for Artificial Intelligence. Outside building data, outside building models for artificial intelligence, the key to AI revolution is data gathering. Most of the time we want to analyze or predict. You see us going online to get data from UCL repository, cargo repository, and foreign-based medical records. Meanwhile, their physiology could be quite different from us because of our climate and other environmental factors. So that data may not tell us the truth about our Nigerian patients. So it is nice if, as medical practitioners, we get our data and build a repository using what? Nigerian patient record. And that will be very helpful to our Center for Artificial Intelligence. in expanding healthcare and also disease prediction. But what we lack is infrastructure, the data quality. And I think when we start building data, quality will improve. Data privacy, when you go to some clinics, you request for information, you are not granted because of privacy. So, but the one you got from foreign repository, nobody asks you for privacy. I don't know, when we go online and we download data, nobody's asking for privacy. But in Nigeria, you say data privacy. So please let us allow our data to be available for research. It also helps you to refine this data and become much better. What is the future of humans and AI? It is a collaborative future. AI can help you process large volume of data. If I tell you a mathematical calculation now, 2 plus 1 plus 3 minus 4 times 5 divided by, before as I'm saying it, when you are writing down, your mindset is kind of slow. But with the AI, through computational technology, is faster and processes faster. So AI has not come to replace humans in any domain. It has only come to make the computer, not the human. AI has not come to make the human better. Human already has its own biological intelligence. But AI has come to make the computer, our devices, our digital tools better, faster, and more reliable, but depending on the training and who has trained these devices. Human intelligence and artificial intelligence must come together. I'm sure with time, you may no longer be hearing about AI, but you may be hearing of what? Augmented intelligence. This is a bridge between human intelligence and AI. This gives us better learning, better decisions, better healthcare. The goal is not to replace the intelligence of the medical professional, but to augment it. The future of medical education and healthcare belongs neither to the human alone, nor to the machine alone, but responsible partnership between both of them. Thank you very much for your time.
Thank you very much, Professor Amadin. He's the Assistant Dean of Faculty of Computing, UNIBEN. Thank you, sir.
Thank you very much, Prof. We would want you to please take down your note down your comments, your questions. We already have online with us Professor Corey. He's going to give us a small presentation. After that, we will then take the questions and the comments as appropriate. Please, Professor Okore, can you hear us? Professor Okore, can you hear us?
We're connecting sound in a bit.
Okay, so you have the floor now, please. Professor Okore, can you hear us? Please, we're waiting for you to begin to address us now. Thank you. Maybe while we're waiting, I'll just read a bit of his biography, a bio-sketch. He's a keen medical educator, especially in the safe, effective, and responsible use of medicines, and is active in research in this subject area. His wealth of knowledge and experience in medical education has enabled him to conceptualize the importance of education and training in a spiral curriculum and as part of the medical education continuum. Can you hear us now, Prof? Is he muted? Prof, can you hear us at all? So you can hear us, it just, we can't hear.
Yeah, I can hear you very, very clearly, yes. Can you hear me?
It's talking. Yeah, Prof, you can go on. Go ahead and speak with us. Okay, now we're set for you. You can go ahead and talk to us.
We can hear you, please.
You can hear me? Right. Yes.
Say something, Prof.
Yeah, can you hear me? And that's the first question. The second question is, can you see my slides?
Yes, we can see both.
Okay, good. So, I just, afternoon everyone, and special thank you for inviting me to this talk. Not quite sure of the timings, but I'll carry on and you tell me when we run out of time. I did prepare for a 40-minute session. 15 minutes, which I wasn't too sure about. Anyway, I will carry on and you tell me when you've had enough. But, pleasure to be here with you, your annual conference at the College of Medical Sciences at University of Benin. Special thanks to the organizing committee for inviting me, particularly the chair, Professor Rita Momo. So very, very grateful to you. So I'm going to try and delve into the world of AI, just like Professor Ahmadin has done, and that kind of set the scene. And it's in relation to, medical education and healthcare delivery. So the good thing about AI is that it's a rapidly changing area, and there's no one individual who is a world expert yet. So we are sort of making it up as we go along, and also learning day by day. So that's the good thing about it. So it's not. I'm not a world expert in artificial intelligence in relation to medical education and healthcare. I will try to, say. So in summary, I'm just going to talk about what AI is, and what AI is depends on who you talk to. Hopefully I can convince you why AI perhaps is, important in this day and age. And I'm going to give some examples of how we've managed to, or we're trying to adopt AI and provide evidence moving forward for others to utilize AI in different things. Okay.
Recording in progress.
So first and foremost, before we go into the main topic, I'm going to bring you greetings from Sussex in the UK, just to orient you, southeast of England. The main city in Sussex is Brighton. There are one or two other cities, but lots and lots of towns. It's a seaside area, so we're on the coast, and because, we're near water, lots of the campuses look like this, so the university campuses are kind of green, which is fantastic to see in the UK. I work at the Brighton and Sussex Medical School, which is probably a medium-sized medical school. We have over 200 students graduating in medicine every year. And the University Hospitals Sussex Foundation Trust, which has got about 7 hospitals in total. It's one of the bigger trusts in the UK, and that's where my clinical practice runs from. So in the context of this sort of AI, I tried to map everything I do to see whether AI was going to help. And to cut a long story short, most of the stuff I'm involved in is going to be facilitated by AI. All right, this doesn't make me a full proponent of artificial intelligence, but looking at the spread of what I do, AI will facilitate it. And this is the typical day, or in the day of a clinical pharmacologist, and the clinical pharmacologists in the audience will relate to this. All right, so we're usually busier than all the other clinical academics put together. But that's a joke, all right? So this is what I do, and it will infiltrate into that and facilitate what I do. So the question is, what is artificial intelligence? I'm sure Professor Ahmadin must have touched on this, but this is my take on it. Well, it depends on who you ask. Artificial intelligence to some is family. So I read somewhere about someone who has AI, sort of offspring and an AI partner. So it depends on who you ask what artificial intelligence actually is. But it dates back to the early 20th century, actually, when they were attempting at building robots. And it was Alan Turing, the computer scientist and mathematician, who first asked the first question on whether machines can actually think. And he actually developed this imitation game, which is now termed the Turing test, which essentially assessed, the ability of an interrogator to interact with a machine versus a real human being via text. And if the interrogator couldn't, determine the difference, then the machine was good and got good marks in terms of the Turing test. So the first questions around whether machines have intelligence came from, sort of Turing in the 1950s, and this was a paper he published then. But the first terminology of the use of artificial intelligence actually came from someone called John McCarthy, who was an academic in the States somewhere. And in 1956, he described artificial intelligence. That was the first time such a term was used, as the science and engineering of making intelligent machines. Right? So that was the definition from 1956 when it originated. But of course, we know that artificial intelligence is all about utilizing data, machines utilizing data to perform tasks, sort of cutting out some of the steps that perhaps as humans we would have to go through, and as a result making it quite a much more efficient process. So I've underlined the word data there because that's the key thing. What goes in is what comes out. So if you provide AI with good data, what it churns out is quite good as well. So that's artificial intelligence, sort of in a nutshell. This is automation of lots and lots of tasks, utilizing data that already exists and making that a more efficient process. Now, of course, I heard the tail end of Professor Ahmadin's talk there, and he was saying how perhaps AI is not necessarily going to replace people. That was my hearing of the situation, but is going to facilitate what we do. Obviously, there are pros and cons with regards to AI in medical education and healthcare. And the immediate concern is it going to lead to loss of jobs? Are people going to be, rendered redundant because of AI and how we're going to do this? But looking at the pros and cons, on balance, there are more advantages in the sense that perhaps if we embrace AI in the right way, are in control of it, it actually may facilitate our work and make things better, more efficient, more effective. It might even save money and enable us to utilize our brains in other areas, so that there is a balance, but it seems to be in favor of going forwards with it and many more advantages. So the question is, this talk about AI, is it any good? Is it any good? Well, This is from the OECD, and essentially they utilize this, sort of test they call a program for interaction of students assessment or something like that. Essentially they utilize this to assess 15-year-olds in different countries on their use of maths, science and other skills to solve daily problems. And they wanted to pitch the students themselves against AI to find out, how they did, so reading, maths, science, in solving daily problems. And what they found was that actually AI, the greater, the more recent or the more developed, as I said, AI is changing every day. As we move along, the subsequent iterations of AI are getting better. So in terms of reading, the more advanced AI, GPT-4, remember we are at GPT 5.6 at the moment, the better they are in relation to the students, in terms of reading, in terms of science. But when it came to maths, the students were better than AI, and no one can explain that. Now I have to add at this point that the OECD comprises around 38 countries, and Nigeria, even though interacts with the OECD, is not part of it. So my explanation is maybe there were no Nigerian students here who could defeat AI in terms of reading, maths and science. But essentially this is evidence that AI, does some thinking, under the influence of human beings. It's apparently so good now, there's evidence that it's good enough that people are saying, those of us in education are going to have to rethink it. Imagine what AI is going to do to essay writing or even assessments. How are we going to assess this? Are we going to now get students or learners to begin to learn how to use AI better? Is that where we should go? Rather than, the sort of old-fashioned traditional method of, yes, you go and search up the literature, you do your write-up, you critique it yourself, you go back to the literature and so on and so forth. It's possible that more time can be, spent doing other things. So this is how it exists right now, in the sense that you have a structured task, you collect information, you draft your text, and then you revise it yourself. And this is with a little help of AI. You give some instructions, and then you prompt AI to give you, more information. Here, you get AI to interrogate itself, to scrutinize itself, after you've given instructions, and then get AI to produce a revision. So this is the kind of way people think education is heading in relation to artificial intelligence. In terms of healthcare, there are quite a few descriptions that have been utilized. These two reviews, they're not that recent, but been highly cited because of their perspective on AI in healthcare, AI in the practice of medicine. They talk about the virtual and the physical, the virtual being things obviously that are, not necessarily palpable, and the physical being things like robots doing, the jobs that humans could have done, whereas the majority of it is virtual. But you can see that there's a wide variation in how AI can be applied in healthcare, and I will sort of come to a bit more detail in terms of what I am aware of that is currently happening. But there's quite a number of applications. In terms of classifying AI, the different types of AI, as I said, I'm no world expert in artificial intelligence, but generally we talk about AI that is able to, that enables us to create new text, images, etc., or AI that can forecast trends or flag risks utilizing previous data, predictive AI. Or you make the AI your agent, and then you give it instructions, and it plans and runs multiple tasks on its own. These are all utilized in healthcare delivery now, and this is an ongoing process, iterative, and people are learning more about it every day. Of course, there are several ways by which you can look at or classify AI. You can classify it based on its capability, based on its speed. But I think in terms of healthcare professionals, I think it's the practical application that is most relevant. So in addition to what has been talked about already, people have also added diagnostic AI, which, as far as I'm concerned, incorporates generative, predictive, and agentic AI anyway, and multimodal, where lots of different kinds of AI are sort of combined. So in terms of healthcare application, these are the types of AI, or this is how it is utilized in practical terms. So the chest X-ray is the most commonly requested and utilized imaging modality everywhere in the world. Okay, the chest X-ray really, really important. And I wanted to demonstrate, practical use of AI based on the evidence we have today. So this was a study that people performed relatively recently. And what they wanted to do was to evaluate the impact of artificial intelligence assisted interpretation versus that of clinicians, frontline clinicians, not necessarily expert radiologists, but frontline clinicians in identifying pneumothoraces. So pneumothorax can sometimes be a challenge to identify on a chest X-ray. So they got 400 X-rays, chest X-rays, half of which had, sort of pneumothoraces, and they allowed, these individuals at different stages in their career, I think about 18 different professionals, to, give their opinion on chest X-rays. And this is what they found in comparison, so the clinician versus the AI. So what they found was actually with AI, if AI assisted the reader, so AI gave an opinion to help, it was much more. It was more sensitive, not much more. It was statistically significant, and gave less false negative results in terms of chest X-ray interpretation. Remember, most commonly requested imaging modality, pneumothorax, can be a challenge to identify. Some clinicians who are used to looking at chest X-rays will know. There was no, sort of real difference in terms of the specificity and false positive detection. But, at least there is some, in terms of pickup, AI was thought to be impressive, all right? So giving, some indication that AI might be useful in facilitating our work. But what was more interesting is that when they looked at the reader sensitivity by grade of clinician, they found that AI facilitated the interpretation of chest X-rays in the context of pneumothorax much more with the junior grade clinicians. So that in itself, usually the junior grade clinicians are the, sort of frontline individuals. They're the first responders. They're the people more likely to be looking at chest X-rays, and they're the people who are more likely to be able to make a decision based on seeing a chest X-ray. So if AI is really important in helping this group, maybe this makes a case for AI to be introduced, particularly for the more junior grade clinicians. Now that's quite impressive. That's looking at the X-rays, but the question is, in medicine we always ask questions and we always depend our judgments on the evidence. What is the evidence in terms of it making a difference to outcomes? Now this is the largest AI-based chest X-ray, type, sort of study, the randomized controlled trial. And what they did was they looked at, 97,000 chest X-rays in various centers. And what they wanted to find was that in relation to detection or treatment or outcomes with lung cancer, whether AI made a difference, because that's where the money is. Because if it saves us time, makes us more accurate with our detection, then it's got to translate into sort of clinical outcomes, which is what we as clinicians really base our decisions on. So this is what they found. What they found was there was hardly any difference, particularly when you looked at time to lung cancer diagnosis and time to cancer treatment starting, which are two things that will make a huge difference. The only significant difference was when the time from chest X-ray being performed to the chest X-ray report being produced. So yes, it may look fancy, it might help us in terms of interpretation, but looking at this sort of study, it doesn't seem to make or translate into affecting outcomes positively. So this is something we need to be careful of. AI seemingly is fantastic and obviously helpful, but we need more evidence that will translate into actual clinical outcomes. All right. So here we can see all those 97,000 chest X-rays in relation to looking at outcomes. No difference with AI prioritization. But what it did do is that it, reduced the time it took between the chest X-ray being performed and the chest X-ray and the radiologist producing a report. All right, so made us more efficient, but didn't translate into outcomes. So we need more data. We really do need more data. And before we embark on such projects, we do need to ensure that we understand fully what difference it's going to make. Of course, there are emerging issues and challenges with regards to the use of AI in healthcare and education. There's the ethical, regulatory, and security considerations, which is sort of important. And to be fair, in all fairness, lots of organizations are onto this. Now, when does AI go too far? All right, when does it go too far? Who determines that it's gone too far? And so on. How does that affect the security of the whole world? How does that affect equity? And so on. So lots of organizations, including the African Union, are sort of empowered by what is going on and are looking at this. So we do need regulation. It is an emerging issue and a challenge. Now, the black box nature of many AI models, you put the information in and then it churns out some sort of results. Now, as clinicians who base our decisions largely on evidence-based practice, some of us believe it's just magic and, find it a bit, sort of strange that happens. So that's the black box nature of many AI models, and unfortunately that affects trust. So for that to get better, the trust of clinicians needs to improve. We've just talked about a robust evidence base. There are pockets of data suggesting that AI is good in healthcare and perhaps education. But we do need some more evidence. And we're talking about AI in healthcare, but have we empowered our students, our learners who are coming through? Remember, medicine is a continuum. Healthcare professions is a continuum and starts in the undergraduate stage, gets into the postgraduate stage, but continues even for those of us who are thought to have reached a certain level in our career in terms of continuing professional development. So have we provided for this? If we're not preparing our learners, and that includes me, by the way, then how can we apply AI efficiently? So these are some of the emerging challenges as a result of the introduction of AI. Of course, the environmental impact. It's not all good. We're talking about climate change, and so on. The amount of electricity, the amount of water that's utilized in terms of AI is huge. It's immense. We need to think about that. That is an issue, and the impact of AI on the environment. Is it going to stop people from thinking? It's going to promote perhaps passive learning. There's no need to actively learn anymore if AI is going to do it all for you. Some people might argue that that's not a problem because AI is there to do it for you. We've talked about labor displacement. People going to lose jobs. Is it going to take over jobs? And global competition. Is that going to create an inequity? The people in the global south, are they at a disadvantage in terms of AI? Are they going to be left behind? These are all questions and emerging issues and challenges. So it's not all that glitters that is gold, and these are all things that people are beginning to look at right now. So I work in the National Health Service in the UK, right? So very recently, as recently as last year, They've sort of, put together a 10-year plan. And the 10-year plan has 3 major strategic shifts. And that's a shift from sickness to prevention. So going back to the basics and emphasizing prevention, because that is thought to be, much more, beneficial to any healthcare system. From moving the care from hospitals, like where I work, to the community, maybe moving it closer to the patient. That is thought to, and there's evidence to suggest that that is beneficial and benefits the patient, in terms of outcomes, healthcare outcomes. But there's also one more, from analog to digital. There's this emphasis on digital, and this is most pertinent, in this talk. So, the National Health Service is a service where you get, care at the point of need, okay? Not like many other healthcare systems, certainly not necessarily like the one we are used to in Nigeria. But they've realized that, moving from analog to digital invariably is going to benefit the patient. So as a result of that, there's a huge emphasis on artificial intelligence, and they want to, employ it to cut waiting times, to, generally improve care for millions. So this is a, the trajectory in Western nation, in the United Kingdom. They want to embrace, sorts of artificial intelligence and use it for what will benefit the patients most. So practically, the way it's used in the NHS, it's used as a triage tool. It tells patients how to access the appropriate healthcare by means of an app. So this is already in use. We talk about ambient voice technology. So one example is Heidi, and essentially what this does is, as you're consulting, this AI tool is taking notes. So, I say that with skepticism, because, I think with every iteration or program that's developed, it gets better. But there's a lot of hallucinations in the sense that these tools sometimes hear things that, clinicians haven't said. But what the whole idea is, if it takes away the time to write and document, and there's an electronic process, it might free clinicians up to see more. In some NHS trusts in the UK, they're now promoting this so that they can increase the number of patients that we see in our clinics, which it is debatable, right? So that's a place that's being used. Imaging analysis, I've shown you some data. In fact, when I look at a chest X-ray, there is an AI report, which I don't actually look at the moment. I depend on the radiologist. But they generate an AI report, and I think they're still collecting data to see how good this is. And this will extend to other scans. It's used in skin and ECG analytics, precision medicine. It's not one size fits all anymore, including with regards to genomics. AI is something that can be introduced to make that process better. And drug discovery and development, which is close to my heart. If the life cycle of the drug can be affected in such a way that drugs are produced in a shorter time and investing less in terms of resources, that's a good thing. So these are the plans that exist in the UK, and they're working at pace in order to implement all of these. So the question is, talking about all the stuff I'm doing in the UK, what about Nigeria? Well, Nigeria, there is hope. There is hope. Remember, this happened last year, I think, yeah? Nigeria launched an AI scaling hub in collaboration with the Gates Foundation. And this is in recognition of what it can do. And I can tell you that Nigeria is actually, in Africa, one of the foremost countries in terms of embracing AI and trying to develop it. I hope that we embrace it fully, and learn from how things are going. I hope that we are not left behind, but this is encouraging. More local to you, this was heartwarming. Uniben mobilizing different stakeholders to support your AI center. This is an opportunity for collaboration. People in the College of Medical Sciences should collaborate with colleagues in the rest of the university to tap into what this AI center is going to do. All right, so you know it's all heartwarming news, and Nigeria hopefully is not left behind in the story. So I'm just going to give you two examples of how we've tried to sort of investigate. You know, we've tried to investigate. We're not using it as yet. This is still a research tool, but you know, AI use in medical education. So this has been already been published, and essentially it was our sort of attempt to look at whether AI can assist in giving feedback in pharmacology. That's my area of expertise. And essentially it's based on evidence, you know, even more recent evidence, that students utilize feedback to shape their learning. All right, so it's quite good for them to have feedback. The problem is it takes a lot of time and effort for faculty, and we haven't got enough to go around to give the amount of feedback that students nowadays want. Remember, the students we're teaching, or the students that are learning now, are in an era of instant gratification. So instant gratification in the sense that the students want the information there and then, and they want the correct information, and that's the way the world actually is now. So we've explored this in terms of pharmacology education, and we want to see whether, you know, we can utilize AI to give feedback. So we looked for a program. As I said, we produce over 200 doctors a year. That will be too big an ask. So we chose a program in the medical school, a physician associate program, which is at master's level, but they have a clinical course. So we chose them in the sense that one of the year groups was 36 students, and what we wanted to do was utilize formative short answer questions, SAQs, based on, you know, various aspects of pharmacology, to see whether they can utilize this in their own time, and then AI can provide feedback that is good for their learning. Right? So that's essentially what we've done. And we worked on an AI model using, you know, rubrics and curated pharmacology references that already exist, and the whole idea was to, you know, get faculty to moderate that and send it out to students, you know, and we looked at what the students thought about this. We looked at what, you know, whether, you know, in terms of feasibility and accuracy, it was good. And we took a subset of the data to find out whether there was any, sort of difference between GPT and the faculty. Okay.
Yeah.
So I'm just looking at the message that Professor Momo sent me. The chairman wants to round up. He needs to leave. So unfortunately, I was given a slot for 40 minutes, and it's I guess I have to sort of run through certain things. Anyway, I'm going to round up in the next sort of few minutes. But I think it's just, if I had known, I would have made it a shorter talk. I just prepared the talk according to the timings. Okay, so this is what we wanted to achieve.
Professor
with.
Can you hear me? We wanted you to summarize a bit, because we want to have some questions and answers and interactive sessions with you and the other panelists.
Not a problem. I will. I can stop now. When we can. We can have that Q&A. It's just I prepared for a 40-minute talk, and that's what I was given. So that's the thing. But that's okay. That's okay. That's all right. So I can stop sharing now, and we can have the Q&A now.
No, you can summarize in say 5 minutes. Any other important points, then we'll take them in the Q&A. You can just summarize. That's what it was saying.
You want me to summarize? Okay.
Yeah.
Okay. All right. Well, I'll skip my, because I was going to show you two examples where we've done a bit of research trying to develop these things. So my thoughts then, and then we can, So my reflection. So I think AI, there's no going back. I think it's here already. And, I think we need to, embrace it. But we need to embrace it within the limits of, what is useful so that we remain in control and so that it is a facilitator rather than a replacer of what we actually do. As you can see, we need more robust evidence base. And, I approach AI with quite cautious optimism. Those are, some of my thoughts. So, in conclusion, I would say that there is a role for AI in medical education and healthcare. I think it's important for us to control the narrative, as clinical academics or healthcare professionals. More research is required, and this is where the College of Medical Sciences can get involved directly. It will require the appropriate investment, which is why it was heartwarming to see money being raised for the AI Center at the University of Benin. And collaboration is key. It's not for one profession; it's across healthcare professionals. So it's really important that we collaborate and understand that it's for everyone, and where there is power in numbers. So I'm just going to stop there. I'm going to stop the share, and hand it back to the chair.
Professor Korea, I can't thank you enough. Thank you so much for this brilliant lecture and delivery. We are very grateful to you. We'll ask members of the audience if you have a comment, a question. Maybe we just entertain some. It will be helpful if you write it down and send to us, because we do not want a situation where you take a long time to articulate your comment or your question. But if you know you're going to be brief, we can just take a few questions before we come back to the panelists to give some answers. Okay, I'll ask Professor Adelia to make a few remarks while we just identify any other person who wants to make a comment.
All right, thank you very much. As we put together our questions and comments, a few remarks might just be useful. I must thank you very much, Professor Okorie, and also apologize for shortening your time. If we had the opportunity, we'll give you all day, because we have a lot to learn from you. I've looked you up online, and I've seen that you've done some work in these areas that you're talking about. I'm particularly impressed about your work on the feedback system using using the GPT-4 model. I noticed, I saw that online. You alluded to that study only moments ago, which is what I think we can possibly adopt in facilitating learning for students. I'm also intrigued by the fact that you used time as a measure of determining the benefit of that study. Hopefully it can be scaled up to translate to something beneficial in learning. With time, we will get there. I also want to thank Professor Amadi for what he has shared with us. One aspect which I want to ask Professor Amadi to please prepare to talk about a little more is his views. What are your views about issues about anonymization of data? Would you say that we are apparently lazy about anonymizing data, and to compensate for that laziness, we put barriers to access? Instead of anonymizing data, we put barriers, and we think that by placing barriers, we are being technical. That's the mentality that some seem to have. Whereas big data needs our data. in order to function with AI. There's no alternative to it. So these are issues I think we should be able to chew on. Does Professor Okore want to respond very briefly to how his model can be enlarged for bigger use while we wait for Professor Amadi to talk about data anonymization as a way out?
Okay, sir, before Professor Okore responds, please, this information is for those doing poster.
I am so sorry. The last bit of, I think I heard how it can be upscaled. Is that what you're trying to say? How what we're doing can be upscaled?
Yes.
Is that the under?
Yes. Yes.
Okay.
Right.
So I mean we chose we were very sheepish. We knew that there would be a huge amount of work, so we chose a program where there were not many students. Now, obviously, to generalize some of our findings, we need bigger studies. So that's the next plan. We need properly funded studies. This is a novel area, actually. Looking at the literature, you won't find very much on the use of AI for feedback and for, in particular, for standard setting, which is the second piece of work I was going to present. So in terms of upscaling and generalizability, we do need more data. So it's seemingly good. There is a bit of modification and refinement that needs to happen. But all in all, I think, just like what I was saying, we need the data to be a bit more robust before we can say, hand on heart, that this is a good idea and it will work for students. But if it does work for students, it will be fantastic in the sense that it will save time of faculty. It will, increase the student experience and possibly translate into, better outcomes for patients, because these are people we're trying to learn, get them to learn the best that they could possibly learn so that it translates into better outcomes for patients. So upscaling on its way, generalizability on its way, but we need a bit more evidence.
Thank you very much. So we're going to take just 4 questions.
We'll pass in the mic round now,
We'll
sir.
pass the mic. Please don't take more than a minute for your question or your comment. We're just going to take 4 persons. I've recognized 4 persons. Any other person can please. I don't know.
Thank you very much. Can I?
So please, 1 minute, Professor Isara.
Yes.
Any other person you can just write it out like this, and you can send it to the ushers. Thank you.
My question is on area of AI in medical education. As we march towards embracing AI, what are the modalities for quality control that were put in place to ensure efficient use? For example, in projects writing. As we're writing an undergraduate, postgraduate project, with AI, it can be written in 30 minutes from chapter 1 to chapter 5. So how do you reconcile that? Thank you.
Okay, question number 2, please. Please, you can stay close to where you are. Let's pass the mic because of if you stay close to the speakers, you're going to have a disruption.
Thank you very much for your presentation. My question is, are there platforms available where the knowledge on how to use AI tools can be accessed for free? And if yes, what are these platforms and how do we access them? Thank you.
Thank you. Number 3, that lady at the back, and then the number 4 is Professor Adubami. Okay, sir.
Thank you very much for your presentation. I have 2 questions. The first question is on data privacy, and it was addressed. But I still have a question that if we are going to automize sharing our data to make AI useful for healthcare, how far is too far in the information sharing? Because I quite understand the concerns with data privacy in healthcare. But how far is too far for data sharing, and what's the access that people can get? Because most of the AI tools are programmed with AI, and that means it can be broken with AI and accessed with AI, as I think it. Then the next thing is the automation of the programs, because I believe there's a way a system can be built that it outgrows whoever builds the system. So how far can it go, and the ethical concerns in AI that, oh, can we say let's put a stop to how far, something we've already started, and when do we put a stop to it for the ethical consideration? Because it's now looking like we're adding more work to the work we have to do in healthcare. If we're now seeing that AI can bring hallucinations and false diagnoses and things that we're not so certain compared to the human intelligence, that means we now have to think critically on how to decipher if the information AI is giving us is helping us or not. So that looks like double burden of work. Thank you.
Okay, Professor Adobami.
Thank you very much. I think the first question goes to, okay, director of AI university is not available. I just want to find out, does University of Benin have AI courses now being taught as part of general studies? Or is there a plan to present to the Senate so that it will be taught formally to students as they come into university? Then the second question goes to the College of Medical Sciences. I think the provost or deputy provost should be here. If there's already AI courses being taught at the fractional level, in 100 level, are there AI courses being taught maybe in 200 or 300 level in medicine that are a bit targeted towards medical practice to form as a foundation for doctors when they eventually graduate from medical school? Thank you.
Okay, I'll just preempt Professor Amadine here. First of all, I want you to understand that in training these AI models, in all this machine learning, there are multiple levels of anonymizing data that are inbuilt into those things. The reason is not far-fetched because of the challenges that can occur, because you have to train this AI on anonymized data as much as possible. We all have seen in the last few weeks how many of these companies, Elon Musk, even the head of Meta has talked about how their AI has hacked into all sorts of systems. If you don't anonymize data, there's no way you're going to prevent your AI from, because AI are not trained in ethics, in medical ethics. And if I remember correctly, when you talk about anonymization, there are about more than 4 steps. The idea is to make sure that it's very difficult or near impossible for you to be able to know the individual person that's involved. But beyond that, there are other things, data that we collect in our clinical settings that can be routinely anonymized. And some of our digital health records are being programmed in such a way that they can do that automatically and encrypt some of these things automatically. But I want us to understand that anything that has to do with this, there's a human input, and there's also a learning point where before you can release it into society to use, there must be checks in such a way, because somebody has to be held liable if there are issues with that. I think I'll just stop in that and allow Professor Amadine, because I do have some questions here written on. Professor Amadine, please go ahead.
Thank you very much. I noted 5 questions, and they all centered around concerns with AI. During my presentation, I advised that we should not fear AI. Rather, be afraid of, 1, the computer, and secondly, you that is also what? Instructing the computer. AI is not our enemy. AI is just a servant. On the first question about anonymizing data, possibly that's the reason why African or Nigerian data is not available for research. When we go online to download data, you don't see Mr. John, neither do we see Miss Mary. What we see there is P1, P2, up to PN, where the P's could represent what? Patient IDs. So the first step of anonymizing data is to exclude bioinformation about that particular patient. Because nobody is going to ask for who is P1, because we acknowledge the fact that the center or the persons that put forward this data are credible enough for us to go forward to start verifying if P1 is John and that John actually suffers from heart attack. No. So we're not interested in your name or who you are. We're only interested in your ID, P1, P2. Therefore, if there is going to be a leak in anonymity of patient information, it is not AI, it is the administrator. Who? Human being. The human is the challenge, not and never, as we speak today, yet not AI, but what? Humans. It is the humans that will go and tell that patient P4 number is, let's say, our president. People will be interested. I'm sure if you Google or you search now, you see a data about the Nigerian president, it will capture more attention than data about myself. So we say, just give us the patient's ID. We want to assume that the person, the practitioner that recorded that data is trustworthy enough, rather than I now go and verify if this case is true. So basically the job is not about data anonymity, but the custodians of this data, how ethical are they? So that solves that. The second question talks about AI and medical education. Oh, project being written in 30 minutes. I think that's the question, right?
Yes.
So I'll encourage it. Yes. If the project can be written in 10 seconds, yes. I encourage it. Yes. Because in those days, our fathers used to have hectares of land. And that's why they give birth to so many children. And they'll take 20 children. The more children you have, the more hectares of land you'll be able to farm for that season. But today, what do we have? Tractors. Intelligent machines. So, with just a single child, or no child at all, machines will do the job for you. Are we getting it? AI is only an information provider and organizer. Do you know what you do to these students, like I do to my students? We are still supervising our defenses on Wednesday. We wait for them on defense day. A student comes to me with a project from chapter 1 to 5, not even bringing chapter 1 first before chapter 2. So definitely I know it's AI. So students, if you want to submit a project, submit it in bits, not all at once. Your supervisor will catch you. So submit it in bits. Then secondly, there are some markers. Let me not cast the update. But there are some markers. When you look at a document, you know it's generated. There are some hyphens, bold, unnecessary comments, and you will just know repetitions. It will tell you a concept in chapter 1. You see that same concept be repeated in chapter 2, and you see summary on every chapter. These are markers that is AI generated. Now, ask the student to defend it. A student has come with chapter 1. Drop it on your table. Tell me about your work. The goal of AI is to train you. Now that AI has helped you in producing the project, have you been trained? So as teachers, we should not be too concerned about the tool that the students use to do the job, but the cross is, has this student been trained? Can he remember what AI have taught this person? So that is what we should focus on. So please continue using AI for your project, but be able to defend yourself.
Okay.
AI free.
Okay, yes.
AI platform. Is it free? We love free things too much in this country. That is, in fact, most AI platforms at level 1, they are free. But if you want one that are better trained with good models, you need to pay for it. Somebody have created this and it's commercially available also. So when you go for the paid version, that project you think is written in 30 minutes can be written in 2 seconds. When you go for the paid ones, because it's commercial. Yes, there are platforms you can learn for free. If you are online, even if you have a profile on LinkedIn, they share updates for free online coaching on how to use AI and AI models, and very nice. Then number 4, I did say it's 5 questions. Number 4, oh, there are 6, 5. How can data be assessed for bad intent And when can we put a stop to the use of AI? Ethical is you, not AI, is you. When can you tell someone to stop drinking? Is when he feels that he's tipsy. So when you feel that AI is leading you astray, you can on your own stop using it. That you stop using it does not mean that I will stop using it. So it's a person thing, not an AI thing. And AI data being accessed, I said at the beginning, for the data to be anonymous, the providers of the data must classify it in a way that do not reflect individual identity. Lastly, AI courses being taught as general courses, general study courses. For now, University of Benin, as far as I know, don't have an AI course in general studies. But I had a discussion with the director of general studies, Professor Homba, some weeks back, and he already intimated me that NUC is already making that plan available, where AI courses will now be made available as general study courses. Why that is in vogue? The Faculty of Computing has some AI courses that you can leverage on. Then, why not use your 30% of CCMAS? Instead of creating a course independent to your own, to yourself, why not come to Faculty of Computing and take a course there as related to AI as part of your 30% CCMAS? Thank you.
Okay, I want to thank you so much. Some of the questions, at least one of the questions here is already been answered when I was asking, as medical students, how can we effectively and responsibly use AI tools to support medical research, from identifying research questions and conducting literature search, critical appraisal, data analysis, and all the different aspects. I'll just add something to this. There is the issue of plagiarism. There's the issue of sitting down and just doing a work that doesn't exist, and that itself is academic fraud. So you can sit down. Yeah, you can talk about the use of AI, but you cannot use AI to generate your data. After generating your data, analyze it, and then go ahead and do everything else. That's academic fraud.
Yes, I very much agree with you. AI cannot generate data for you. For those that have used AI, if you ask AI to give you a report, it will ask you, upload your data set. It always asks you to do that.
The reason why I'm saying so is because people can generate all sorts of prompts and then use that and to generate a lot of stuff. You'll be shocked how you can get around some of these things. So we do know that there are some things when it comes to ethics in research. There are some things that are eternal, that are consistent. We know that it's possible for me. I can sit down in my office and get a spreadsheet and just hallucinate data, and then you go ahead and do that. And in this day of AI, you can have a situation where that can be accentuated and cause problems. Now, the main challenge, one of the big challenges you will understand is that you will not be solving real-life situations. And that's why there are ethical issues concerning that. And if you do generate data like that and you use it to now train an AI, you are not even helping the AI itself. And you're not contributing to learning and to knowledge or whatever. So what you must understand, there are some ethical use for this. So if, for instance, you want to write a research question, you want to identify research gaps, you want to help to make your research much better, and all that, yes, ethical use of AI, there's no way you can stop that now. However, it's as part of usual plagiarism and all the rest, we would test and we should be testing for some of those. I just put that there to then two questions here and then we'll close on this. This is for Professor Kori. I hope he's still with us. The question was how are you using AI in teaching your pharmacology? I think you have answered it to an extent. And then there's a question here. I think I'll just dismiss this. Being a surgeon myself, so I think I can dismiss this. It says, does the advance of AI cover for robotic surgery and any other similar related medical application? To an extent, yes. Because there is some embedded AI in many of these surgical tools and robotic surgery as it were. But robotic surgery by itself just like laparoscopic surgery. It's still the surgeon that does the surgery. It's just that it just so happens that you are doing it with a tool. And there are some aspects of robotic surgery that have some input on augmented reality and some of all these other parts. But as to the surgery itself, it's still the surgeon that determines and that does the surgery completely and totally. So, and of course we do know that what is now happening, like Professor Amadi mentioned when he was talking about augmentations, we are looking at neural networks where human beings are now going to be augmented by these chips and this AI transmitting directly to our brains or to our sensory organs to be able to take decisions. Maybe that's the place of AI in the future, especially since AI is already embedded in most electronic medical records. AI is already embedded in practically all electronic health records right now as it stands. AI is embedded in probably most diagnostics. There are many diagnostic devices that have AI embedded, whether it's measuring your blood pressure, or it's measuring your ECG, or it's doing your echo, or it's doing your CT scan. AI is embedded in all of them. And most of the idea for embedding it is to augment and improve your ability to be able to accurately make your diagnosis and improve your clinical decision making. It's the same way it's going to be embedded in our research to help us to become better researchers. So there's this last part I saw, both you and Professor Okori spoke about, when you talked about, maybe I'll call it bots, because that's the normal computer terms you talk about. Some of them I call them voice bots, chat bots, and all the rest. Now, there are many of these. They are essentially like assistants. And many of us may not already know, but they already exist in practically all industry. Today, there are many of your banks or your pension fund administrators and all the rest, you don't need to speak to them directly. You speak to a bot, a chat bot, and it will give you everything you need. You want to get your PIN, you want to know this, you want to apply for this, and now we already have them in medicine. They are already there. They are already embedded in our health records. They can take appointments for you and all the rest. But here's the kicker, because you mentioned about competency-based training for medical students and for all healthcare workers. Can't we use those bots as simulated virtual patients? Because they can give a lot of feedback, very good, constructive, formative feedback to a student who is learning to take a history, for instance, from simulated patients. And that can help in terms of medical learning and training. So maybe I'll leave that to you and then Professor Okori to make that last comment, and then we'll round this up. Professor Okori, are you still with us?
Yes, thank you. So I've been listening in, straining my ears. You know, it's better to be there. I wish I was there with you next time. So I heard a few of the questions. You know, I'm going to start with quality control. Someone was slightly concerned about quality control. Well, I mean, the gold standard is humans. You know, I mean, there's a saying, garbage in, garbage out. AI depends on data. And that data is provided by humans, data that already exists. You know, if we wanted to collect new data, we set it up so that it collects new data. And that's where us, you know, sort of, you know, being in charge of AI, whilst embracing it, but controlling what it does. So quality control over time, as we acquire more evidence, maybe things will get better. Because someone also mentioned the fact that there's more work in healthcare with AI around, you know, because we're constantly checking. That's because we haven't got enough data. As there are further iterations of the various AI packages and further refinement, things will get better, you know, and it's just like any other digital resource, you know, things will begin to get better. Someone mentioned how far is too far, and that's where regulation comes in. You know, that's really, really important. And I heard the conversation around you know, where do we stop in terms of, you know, writing our dissertations and theses, you know, and essays? You know, who decides what we shouldn't do. Now, this is not a problem peculiar to the University of Benin. You know, it's global. People are now talking about redefining what education actually is, because AI is there. Our students will dabble into using it, and maybe we've got to, you know, look at ways by which we can empower them by teaching them how to use it best. In our university, we've got a traffic light system, you know, red, amber, green, and what that tells you is when you're meant to use AI or when you're not supposed to use AI. Obviously, if there's no university policy, it's very difficult to hold that against students. So with AI staring us in the face, you know, maybe that's something the College of Medical Sciences, if it hasn't been done before, can actually look at, you know. So there was another comment around, you know, sort of the actual surgery and the actual application. So AI has infiltrated everything. You know, we talked about virtual and physical AI. You know, robotic surgery has been around for a long time. Actually, AI has been around for a long time. You know, I mean, with the advent of the internet and emails and, you know, sort of chatbots and so on and so forth. We've had AI for some time. It's just that it's gone to another level. But we still need to, you know, validate it by means of much more evidence in education and in healthcare. You can see the attraction when governments look at it, and it's going to save money, costs. It's going to make us more efficient, potentially leading into better patient outcomes. You can see the attraction. But it behoves us as, you know, healthcare professionals and academics in the field to hold everything to account, and as we normally would do, base our judgments on evidence, the evidence base. So that evidence base is rather weak at the minute, and it's on us to help provide some of that. So I'm going to stop now because I know, you know, we have run out of time, but you know, happy to make any further contributions.
Thank you, Dr. Corey. You've actually said it all. You've said it all, and I agree with you. So basically, we are on two divides. He and most of you here are from medical fields. We consider you as majorly users, but I'm from the computing field, so we are mainly developers. So we have created these tools, and we encourage usage. Being ethical is a two-way thing. You and then the developer. We try our best to create ethical, you know, restrictions around our tools, but we also advise you to use it. Just like I did give some example before, if you have a weapon, you either use it to defend yourself or commit a crime. Nobody's going to guide you on how to use your weapon. So AI is a weapon. How you use it depends on you. The humanity in you, that is the judge. So please, I will conclude and by reiterating myself, AI is not to be blamed, it's you. Thank you. Thank you.
So I want to, my job here is very simple now, just to tell you thank you, Professor F. Amadi, and of course, Professor Corey, thank you so much. We know we had some challenges logistic-wise, and we had to cut your time. Well, thank you for a very brilliant, well-delivered lecture. And I also want to thank this audience for a robust participation. We're going to be presenting a plaque now, I think.
Thank you very much. Let's put our hands together for the chair, the co-chair for this session. At this point, want to call on our mommy, Double Chief Stephanie Iga-Dosa, to please do us the honor of making the presentation of the plaque to Professor Amadi. Please, ma'am.
All right, while we welcome Double Chief up, I just want to note and also inform us that she's the first medical doctor from the University of Benin. Yes, she is. She's the first female chairman of Edo NMA. Put your hands together for her. And she has the first patented scientific innovation from Uniben as patented by the federal government. A hand-washing device without a tap. And the center leader, Seri, will join her in making this presentation. Professor Mrs. Obarisiabon, please. Thank you, ma'am.
Is the chairman CWC here? Professor Momo, is she on? Okay.
Praise the Lord. I was privileged to be present during your inaugural lecture out of curiosity to learn, say, the new trade. I was raised in the computer era from when one computer occupied a whole room in the University of Glasgow. When I left here after my first medical degree to do a PhD in the University of Glasgow. So I've grown up in the system, learning and relearning and growing with computing. So it's my real privilege to stand before a computer professor. I call them wizards. You're blessed. So on behalf of the College of Medical Sciences, I can say on behalf of the University of Benin, for whom I have a great passion. I'm a citizen of the University of Benin. Haven't been here since the foundation years. I'm a foundation student since 1970. So I've grown and aged gracefully with the University of Benin. So I'm very delighted on behalf of the college, and in particular, the chairman of the local organizing committee, to present to you this plaque in recognition of your great lecture and your continued service to humanity. You're bridging the gap between the new technology and our traditions of providing health care. And I really hope that you would accomplish and follow up with your promise of introducing it into GPS such that we catch them young at 100 level and begin to learn the new language of learning and operations. So thank you very much.
Thank you, Ma. Okay, we'll request Professor Kubo to join in for the pictures as well on the other side. Thank you, sir. Just a minute, Ma. One more picture. Thank you, Ma. Thank you, Ma. Okay. Professor Okpade, Professor Obi to join in as well. Okay, beautiful. So we're going to present the next plaque to our second speaker, Professor Michael Okori. Is going to be received on his behalf. To do that presentation, I want to respectfully welcome Professor Sonny Okegbeme, HOD Community Dentistry, and Professor Fidelis Olumese from Medical Biochemistry to make that presentation. Thank you, sirs. As you come up to help us present the plaque to Professor Michael Okori, that will be received by Professor Okpade.
On behalf of the College of Medical Sciences and the organizing committee, it's my pleasure and honor to present this beautiful plaque to our distinguished presenter, Professor Michael Okori, in recognition of your distinguished contribution as a plenary speaker on AI and digital tools in education and health systems on the 4th annual scientific session and conference of the College of Medical Sciences, University of Benin. We deeply appreciate your presentation. May God bless you. Thank you very much.
So we'll call on Professor Barry Siabon to join them, Center Leader Seri, and Professor Rita Momo, Chair LOC. Thank you.
Thank you, sir. Our next session is still going to be on AI, and we're starting right away. AI in advancing maternal health care. Thank you so much, Professor Okegbeme and Professor Lumese. Thank you, Professor Barisiago. Thank you, ma'am. All right. Thank you, Professor Kugbo. Let's appreciate our panelists and our moderators. Thank you, Professor Korea, for joining us online and making this session very interesting. Thank you, Assistant Dean, Faculty of Computing, UNIBEN. So the next session is AI in advancing maternal health care. We're going to have it's an innovation presentation. It's an innovation presentation that's going to involve medical students and head of department of obstetrics and gynecology. Please, the session is still on, and we request that you still stay along with us. So I'm going to welcome upstage Professor Ehiga Enabudoso, HOD, Obstetrics and Gynecology, UNIBEN, as he anchors from here. He will welcome everybody else that's joining him on the team. Thank you, sir.
Thank you very much. Since morning we've been talking about artificial intelligence, and it looks like a theoretical thing, but I'm privileged to present a set of brand new medical graduates who have not just learned, but they have thought of ways in which to advance maternal health through the use of artificial intelligence. And we've called this particular aspect innovations. As we've heard today, it's one thing to know about artificial intelligence. It's another thing to be able to make sure that it works for us. So, I'm going to be calling upon our brand new medical graduates. Delight, if you know one here. Maureen Etwonovi and Wealth Okafor. So just get glued to your seat and then listen to them present their innovation on artificial intelligence use in maternal health. Thank you very much.
What's the first thing that comes to your mind when you think about artificial intelligence? I'm sure most of us in this room likely thought about ChatGPT. What's the first thing that comes to your mind when you hear about artificial intelligence in healthcare? Now, this is beyond just an application, and it is definitely beyond just electronic health record systems. AI has done so much in improving patient care. And so with this, we want to explore what AI can actually get to do in maternal health care. So, why maternal health care? Now, pregnancy isn't just a single visit to the hospital. It's a journey. And this journey goes from the preconception period down to antenatal care, to labor, and then to delivery. And it also spans through the postpartum period. This journey is time sensitive. This journey is continuous, and decisions made throughout the course of this journey can affect not just one life, but two lives. And so looking at this is an enormous potential for intelligent technology to actually improve healthcare. But before I take you to what technology can actually do, I'd like to walk you through what the antenatal care pathway currently looks like. A woman comes into the antenatal care clinic, and she goes through the booking process. Her history is taken, examinations are done, and investigations are also carried out. She is booked for a routine antenatal visits, and throughout this course, she meets with the midwives for health education. She goes through labor and delivery, down to the postpartum period. And in critically looking at this pathway, we've been able to identify some gaps that we believe that AI can actually contribute to in improving healthcare. Some of the gaps we identified include long waiting times, limited manpower, facility-dependent interaction, delayed care seeking, and information gaps between visits. We also believe that filling one or more of these gaps is going to push maternal care forward in the future. AI across maternal care journey can affect different aspects of maternal care, which includes the antenatal care period, the intrapartum care period, and the postpartum period. But for the course of this presentation, we are going to be looking at the antenatal care process. And some of the areas we believe that AI can actually affect and contribute to positively includes the risk identification, patient education, clinical monitoring, and symptom monitoring and clinical decision support.
We aim to bring this vision from paperwork into existence. So we bring to you 9Care AI. 9Care AI is currently being developed by AI Women Rising in conjunction with Elite Global Intelligence Technologies to explore how artificial intelligence can get to support maternal health care through human-centered innovation. It is currently being developed under the clinical supervision of the Department of Obstetrics and Gynecology in UBTH to ensure the clinical accuracy of the AI tool. 9Care AI is an AI-powered healthcare platform for maternal care which aims to reduce care delays and through early intervention, improve maternal and fetal outcomes. 9Care AI is designed to function around the various points which women get to interact with the antenatal care system. The first point of contact is with the booking. With 9Care AI, the women will be able to start their booking process at home by imputing all their booking details with their smartphone from the comfort of their home, getting to reduce the long waiting times in the hospital. Also, when the information has been imputed, this platform can get to organize the data so that by the time the patient gets to the hospital, the information will just be reviewed by the healthcare practitioners. In addition, the platform is able to assess the risk of the patient using the maternal and pregnancy risk factors that are identified by the information they've already imputed. In addition, the AI platform seeks to improve the connection between the women and the healthcare facilities through various means such as reporting symptoms so that the women will be able to report any symptom they get to experience during the course of their pregnancy without having to wait for their next antenatal appointment. Also, for women who are low-risk patients and do not always have to be in the hospital, there will be the option for virtual consultation. There will be the option for virtual consultations made available. Also, for women who have reported their symptoms and have predefined risk factors, doctors will be able to triage these women and in case of emergency, employ early intervention. So 9Care AI is not meant to be a standalone app. It is meant to actually be an intelligence layer connecting the woman, her information, and the multidisciplinary healthcare team. Now, we have a clinical scenario. Imagine it's Saturday evening, and we have a 26-year-old pregnant woman who is 24 weeks pregnant. She notices something unusual. She notices a symptom, and her next antenatal appointment is in the next few weeks, and she does not want to go to the hospital. She has one of three options. Her first option is to wait until her next appointment. Her second option is to search online or ask family and friends. And the third option is to seek an appropriate clinical pathway. Since majority of us here are clinical or medical personnel, the most plausible option is going to be to seek an appropriate clinical pathway. However, in a real-world setting, which we've gotten to see in a patient, she went ahead and searched online and asked family and outcome. So we know that not everybody would always have this favorable outcome, which is why 9Care AI seeks to make this option available and easy for everybody who wants to seek better care immediately they experience symptoms. So now we want to reimagine the antenatal care journey. So we have a pregnant woman. When she's at home, she's able to impute all her booking details from the comfort of her home. You can see her biodata, you can see her obstetric history. All the history that she needs to take is being taken from the comfort of her home without having to wait for long hours in the hospital before accessing care. So that's how it is. And when she imputes all of this data, it keeps going. It keeps going. So all of that data that is needed to be imputed at home, that can be imputed by the woman at home, is imputed. And by the time she gets to the hospital, she only needs to review her information. Her information is going to be reviewed by the healthcare practitioner instead of taking the history from scratch. So also during the course of her pregnancy, She can also get to stay connected to the hospital because she'll be able to report any symptom that she has during the course of the pregnancy without having to wait until the next appointment. And those adverse outcomes can be averted. So, to tie it all together, AI gets to process, AI gets to structure, AI organizes. However, the clinical responsibility remains human. So like we've been hearing from the very beginning of this conference, AI is meant to augment what we already have, not to replace what we have. It's that the AI platforms and the clinical team work together to improve all outcomes across board. So the question isn't whether or not AI is already in healthcare. It is that what will we do with the technology we have? Will we build it around technology or around people? Care remains primarily human. And that's our vision for 9Care AI.
Now that we have seen how 9Care AI is designed to function, we want to look at what actually makes this different. So first of all, this platform isn't just another communication tool. It actively analyzes data to empower clinical decision making. So first of all, this platform would need to be fed with data. It would run continuously, capturing structures in patients' medical history, the booking details, and other necessary information. Next, it runs on deep learning, so it will now create patterns. But these patterns won't just be hallucinations. They will be based off actual guidelines and protocol that exist already in obstetric and gynecological care. The next, and this is where the innovation actually lies, is the real-world training. It seems that in our context, which is Africa, there aren't actually enough data that captures the complexity in antenatal care. So we intend to train this model with actual real-world clinical data that captures this. Now, this is beyond telemedicine. Telemedicine, as we know, is that it bridges the gaps between patient and the consultant or the clinical healthcare provider. And the way we know this is that through videos or text consultations, this can be done. 9Care AI pushes this a step further, implementing not just virtual consultations for low-risk pregnancy, but also the ability for the patients to have physical consultations while all her data is captured in one system. The next is that the doctors still spend valuable time getting the history in a normal virtual consultation, but seeing that the patient has the opportunity to start her booking at home, it shortens that time. Also, the intelligence function of this platform is that it aids in risk stratification. We know that there's already a system in place, but this just helps the clinician to do this faster. It also helps in triage, and we will make available the needed patient education just as it is provided in the antenatal clinic by the nurses and the midwives. Now, where are we currently at with this product? We are currently working to start a test run with the Department of Obstetrics and Gynecology at the University of Benin Teaching Hospital. We picked UBTH because we want to effectively train this model. And we see that the hospital setting has access to highly diverse and complex mix of obstetric cases necessary for a robust real-world training. The goal of this test run is to, first of all, assess the accuracy of this platform in retrieving patients' data, the usability of the user, and the usability of the platform for the user, and the acceptability amongst the patients. We also want to see if this platform integrates seamlessly into a busy, high-volume clinical workflow. The road ahead for this product is that we plan to expand it beyond the antenatal care period. We want to see how this product will also help in the postpartum care of the patient. This idea was actually coined from the Serena Williams story. I don't know if we are conversant with that. She had a very poor experience in her postpartum care. A little of it started from our intrapartum care, but most of it was our postpartum. And we began to think that, is it possible that we could integrate or create a system that would care for the patient continuously into our postpartum period? So we intend to also integrate maternal mental health screening and support to help to better manage postpartum depression. So we see that 9Care would evolve from an antenatal triage tool into a comprehensive continuous support system for the entire maternal journey. So in conclusion, our vision is that care would still remain in the hands of the human clinical care provider. Thank you for listening.
It's obvious that one of the major challenges in maternal health is that of equity, that of delay, and even that of access. We do believe that with the integration of artificial intelligence into maternal health, we'll be able to take care of some of these issues and then follow the patients continuously. And as has just been presented, the patients have a more reasonable idea. You can even work on even their mental health states, as we're already having in some of the AI systems. And it's our belief that with this product, having been well tested and integrated, that it will be one of those tools that will further improve maternal and newborn care. Thank you very much for listening. Do you have time for questions?
Please, let's put our hands together for the team for an excellent job. At this juncture, we'll just entertain a few questions in the next 5 minutes. If you have questions relating to the presentation, just indicate by raise of hand. Professor Adam Igwe 1. Any other person? Okay, Sister 2, 3. That's fine. 4. Is that all? Okay. Okay, fine. Please quickly.
Okay, the mic is coming down. Thank you, sir.
Thank you very much for that presentation. Well packaged. Lovely concept. But my own question is, you know we have mobile devices and smart devices. I am thinking for the woman in Anigbete or the one in where do you call it again? In my village in Amoke, that doesn't have access to smartphone, how can she benefit from this your Nike?
All right, thank you, sir. We'll take all the questions together and allow for the responses. The second person asking. Okay, Reverend Sister, please. Thank you, ma'am.
Thank you very much for the concept and for the presentation. I think my question is in line with what he has said. Everybody holds phones. Some just use phone for phone calls alone. And there are some of them who are not educated enough to be able to key in all this data into their phone for your platform. How does that work for them? That's my question.
Thank you, Prof. Ma. Number 3? Okay, right behind. Who's number 4? Number 4 is on this side. Okay.
Thank you very much. I want to appreciate you. The work you are doing is a very nice one. So I want to ask this question. In cases of where somebody can, like, you are doing it for women, because you made mention that this thing you are building it for women around. What if in the case where the woman cannot access this application, or like, for example, the thing, does it run online or offline? This application or this AI you are developing, is it going to be an online application or is it going to be an offline application? You know we have network issues in Nigeria. What are you going to do in terms of network issues? Thank you.
So for poor network areas, how can we handle? The last question, she's on this side, please. Thank you.
Thank you very much for your innovation. My question is similar to the first question about somebody who is not educated, because most of the maternal care problems we see are pertaining to uneducated and people that are least exposed to information. How does it benefit her? Also, the sort of question and the risk scoring system is something that has to be updated based on what is obtainable in every hospital. How scalable is this concept? And how much of an understanding in terms of the communication between the clinician and the patient will the app contain? Thank you very much.
Thank you.
All right, thank you very much for your questions. I'd like to say again We are starting now. We haven't developed the product yet. What we have is a web version. And this is, we've not test run it yet. We mentioned in the presentation that we wanted to get to test run how it will be usable by the women who get to use it. There is going to be an option for people who are uneducated to choose their language. But for now, we want to get to test how easy it is, if it's something that can even work with the women that we have currently on ground. And for smartphones, we've thought about that. It's not going to be restricted alone to smartphones because there are options of SMS, USSD codes, and all of that that can be integrated in the future. Then also for the source of no network coverage, yes, that's actually already in the works as well. To see that if this gets to pull through, it will be available for people because we know that in Nigeria, that's the major problem. So data will be stored on offline basis rather than on online basis alone. So that option will be made available subsequently.
Okay, I think it's also important to note that the app would run like an EMR system. So right now it's a website that we have on ground because in building you can't go straight to applications. You have to test the product and ensure that corrections are effectively put in place before you create an actual application. So that's where we are right now. But also noting that since it's running as an EMR system that is a bit mobile, it means that the doctor is always going to be involved. I'm trying to answer the question of understanding in terms of communication between the doctor and the patient. So when the patient fills her information at home, the doctor sees it on the back end when she comes for booking, because at the end of filling her booking details, she's asked to book an appointment. So on coming to the clinic and interacting with her doctor, the information she puts on the platform is verified. And obviously there are certain information that she may not be able to impute on her own. Those are the information the doctor would now clarify and put directly into the platform. So the idea, first of all, is to shorten the waiting time in the clinic and try to reduce overcrowded clinic, because we already understand that there is a burden in the healthcare system of manpower. So that's where we are geared towards facing right now. Thank you.
So we just want to thank you all. Remember that the journey of 1,000 miles begins with one step. Incidentally, there are many steps already that have been taken in this, and then the initial design is already there. So now we're test running, and then just like we talk about artificial intelligence, the deep learning systems needs to be fed with more data, and so with real life experiences, we feed more data, and then that enriches the system itself, and hopefully in the very near future, we expect that once all that has been done, then it can be converted into an app that people can now download directly into their phones. Before we round up, I would like the pregnant woman to also say good afternoon to us. Madam.
Good afternoon, everybody.
Thank you, madam. So thank you all for listening, and stay well.
Group photograph, please. Can we invite the LOC chair to join them? Thank you, ma'am. Okay, other members of this team, please, if you are here, please join them. Other members of this team from O&G department, please join them. Thank you. Thank you, Department of Obstetrics and Gynecology. We want to thank very specially Professor Ehiga Enabudoso and the team. Okay, so we're going to have oral presentations very shortly. All right. All right, so we're going to do lunch simultaneously as we prepare for the scientific presentations. I think the protocol will help us to direct us to pick our lunch packs. They're already packed, so you just pick your lunch pack and come back in so that we continue the scientific presentation. Chair of the scientific presentation and co-chair, Professor Sonny Okegbeme, Professor of Community Dentistry, and Professor Otayenwa Obaisiagbon, Professor of Community Medicine and Public Health, to join, to come up on stage. Thank you. Professor Okegbeme and Professor Obaisiagbon are handling this next session. And so for everyone with oral presentations, I believe they know themselves, we would love for you to come forward a bit so that we can have an order in which you have your presentation. Okay, so we are having a parallel sessions. I've just been informed that we're having parallel sessions. There's going to be one here, and there's going to be one on the first gallery. So for the one here, Professor Okegbeme and Professor Obaisiagbon are here. For the one on the gallery, it's going to be handled by Professor Isara and Professor Ehigiamusoy. Professor Isara and Professor Ehigiamusoy, please, you're going to... Professor Isara, Professor Alphonsus Isara and Professor Ehigiamusoy are going to take the parallel session on the first gallery. Thank you, sirs. And so for those that are presenting on strengthening health systems, I'm just following the brochure, page 21. For those of us presenting to Professor Okegbeme and Professor Obaisiagbon, please, you can come up on stage here. We have seats for you here. While those that are presenting to Professor Isara and Professor Ehigiamusoy, you can just move there already. I believe the protocol are helping us with getting our lunch already, so please let that also happen at the same time. I guess we're going to get some people to be part of that audience as well. We'll get there.
Good afternoon. The following persons should please move to the first gallery. Odi Kemere QC et al. On health systems gaps in child nutrition. Number 2, economic instability and
So for the two parallel sessions, you are at liberty. I'm talking to members of the audience now and our students. You are at liberty to choose whichever to join. If you want to join this session, you would come forward to stay in front here. If you want to join the second session up on the first gallery, then you go up on the first gallery. Okay, but the session here is on strengthening health systems, the presentation for up here, while that for the gallery is on social determinants of health, sexual reproductive health. So whichever is your area of interest, if you look at your brochure, if you don't have a physical copy, if you are scanned from your tag, you will see it listed there. So you can make a choice of where to join. If you want to join the one for strengthening health systems, that means you're going to move forward. We may no longer worry about the reserved nature of the seats so that you can hear us clearly. But if you're going to be on the other side for determinants of health, then you move to join that gathering.
For the social determinants of health, the following authors are kindly requested to please proceed upstairs. Odikemere QC, Nebe CJ, Wongogu JC, Izeko CO. The chairs for the sessions are Professor Alfonso Zisara and Professor Egiamuso. We start now. Thank you. Now, those who are interested in these kinds of research, please go upstairs as well. It's going to be the best session.
Let me call the names. Okay, for session C, we have Masagbo CP. We have Ayin Tombra Awudu. We have Ofure Ogbidi. We have Dr. Okonji. We have Dr. Ihuriona, Dr. Akpalaba, Sado Ehinome. Sado Ehinome, and then one other person. The team for uptake and utilization of electronic health records. Please, I think the presenters for this will come up, okay?
Please, the lead presenters, we'll need you up. We have seats for you. Thank you. The lead presenters, so that we can make it fluid. The lead presenters for strengthening health systems, Mazagbo, Caleb, Ayi Batombra Awudu, Ofure Ogbidi, Dr. Konji, Eshirame, Dr. Ikurana, Akpalaba, and Sado EO. Please, we have seats for you here. Thank you. In front, you can take seats in front, we'll just indicate. So if you are joining in the other session, please feel free to join the gallery, the first gallery. Thank you. We want to appreciate some of our other professors and consultants that have been here from the beginning. Professor Idogun is here. We welcome you, sir. Thank you, sir. Professor Akoria was with us a while ago. Former Commissioner for Health, HOD, Internal Medicine, and everyone else that has... Professor Kaku, thank you, ma. I know LOC is very active. Thank you, LOC. So we'll be ready to start here shortly. Dr. Ikurona, please, are you there or here? Your name is on the list here. Okay. Professor Obi, please, we need your attention. Professor Obi, please, we need your attention, sir. Okay. Okay. Etuo Mori, Etuo Move Morin. Okay.
World Health Organization has defined vaccine hesitancy as the refusal or delay
classrooms, teaching and learning resources that help to set up this program. Having done this, the school was able to succeed, having successfully gained having had a successful verification exercise and approval from the AUC, Nigerian University Commission, the school went ahead to admit students. The pioneer students were 20 in number. They have risen to a maximum of 28. This, as you can see, is some of the resources for learning and teaching provided by the school. Although the outcome is good, the pioneer students from 20 decreased to 4 due to migration to Western countries for these students to further their education, and some of them retook JAM and entered other departments. So the pioneer students were remaining only 4. Apart from this challenge, other challenges abound: funding, manpower, and infrastructure. So, in conclusion, although there were a lot of challenges, the school progressed and was able to reach a world-class standard. So this is a model that can be explored by any unit, department, or university that wish to increase or that used to develop new curriculum or new units to strengthen healthcare delivery. This can be explored by other universities and units. Thank you.
Although I will be presenting comparative study on hazardous internal precaution for healthcare workers at the University of Benin Teaching Hospital.
Good afternoon, professors, consultants, training and coaching, and ladies and gentlemen. I'll be presenting a comparative study on the adherence to standard precautions for healthcare workers at the University of Benin Teaching Hospital. My name is Elena Sadon, and I'm presenting on behalf of the co-authors of James Stewart. Healthcare associated infections remain an important patient and safety public health problem. A standard precaution at first line of defense. They are an essential infection prevention measure applied to every patient, regardless of infection status. However, compliance remains inaccurate, and this is a challenge, especially in resource-limited settings like Nigeria. The aim of our study was to see if there is a difference between how doctors and nurses understand and apply standard precautions and see if there are any factors that may affect adherence. We conducted a descriptive cross-sectional study among 307 healthcare workers, which consisted of 199 doctors and 161 nurses, using a certified multi-stage sampling technique. We used a structured self-administered questionnaire adapted from a validated process to collect social demographic, knowledge, and compliance data from the respondent. Knowledge was called using 1 point for each correspondent and was classified on program using contact marks for 60%. The same was not applied using a 5.9 share. In various atmospheric analyses were employed to explore associations between independent and outcome variables statistically set at P less than 0.05. The mean age for doctors was 35.1 years, the standard deviation of 8.03 years, and 36.18, the standard deviation of 11.01 years for nurses. However, the difference between doctors was not specified to nurses. Majority of populations were not 262 years, compared to 5% of total population. For each category, the most represented job positions were in the general register, which consisted of 4.10% of doctors, and senior nursing officers is 2% of nurses. This figure shows the difference of nurses on good knowledge and good compliance. For good knowledge, 9.5% of doctors reported good knowledge, while 81.2% of nurses reported good knowledge. And given the change to the 5% key value are very considerable. For compliance, 95% of doctors consider good compliance, and 98.2% of nurses consider good compliance. However, different schools will not accept significant. However, in some areas of compliance, for example, the Department of Legal, 6.2% of doctors always report, while 6.9% of nurses always report. And the difference between the two is that key value at 0.001. These are the barriers that parents reported as respondents. Reported a lack of personal protective equipment, inadequate water and soap supply, inadequate hand gloves supply, lack of training and supervision in emergency situations. However, doctors reported more of lack of personal protective equipment and inadequate water supply compared to nurses, and different tools to affect key value at 0.001. Our findings show that doctors had better knowledge of nurses, and this is possibly due to differences in depth and focus on mental health. And this was consistent with only done in Ababa Ethiopia, where doctors instituted better knowledge of nurses. However, theoretical knowledge does not always translate to practice. We found that nurses demonstrated slightly better performance, particularly when non-recurrent. And this is possibly due to greater involvement in direct patient care and bedside procedures requiring continuous patient care. This contrasted with a study done in hospital in Bayelsa State and Texas, where lower compliance levels were found. Ultimately, top barriers reported by respondents reflect real-world perception of organizational challenges to infection prevention and research process. And these barriers will increase healthcare workers' risk of infection and occupational exposure, while contributing to increased healthcare accessibility and medication. In conclusion, doctors and nurses demonstrated good knowledge and compliance with all education. However, the important gaps in specific aspects of the knowledge described. We recommend ensuring consistent availability of personal protective and implementing targeted training that addresses knowledge deficiencies in youth care. And this is essential to improve their appearance and reduce healthcare accessibility. So my selected references. Thank you.
Thank you very much, Dr. Sabi. That ends the this session. I will now follow the picture.
Thank you very much, Mr. Chair. Well known to the presenters, everyone was present for this session. This chapter brought together 8 abstracts, beautifully presented, and the presenters examined how we can deliver safer, more respectful, more responsive care across the various levels of the Nigerian health system. The papers clustered around 3 key health system building blocks: service delivery, health workforce, and health information systems governance. With respect to service delivery and community access, the first presenter explored vaccine uptake and hesitancy among pregnant women in antenatal care in Southern Nigeria. The next presenter looked at prostate cancer screening, barriers and facilitators among public transport drivers in the city. Dr. Ekorena et al. Gave voice to adolescents and their readiness to transit from pediatric clinics to adult neurology services, while Dr. Calaban and her team presented an integrated ENT, audiology, and speech therapy model as experienced in Ondo State, showing us a collaborative approach to specialist care. With respect to health service and health service workforce, health workforce and quality of care, our researchers assess knowledge and experiences of respectful maternal care among postnatal mothers in the institute. Another presenter explored prevalence and drivers of workplace violence against nurses in EBTH and its implications for workforce development. Adherence to standard precautions among healthcare workers in EBTH was also examined in this session. With respect to systems and infrastructure, the final paper evaluated the uptake and utilization of electronic health record system across public and private hospitals in the institute. Mr. Chairman, sir, together these studies highlight that strengthening health systems require addressing both people and processes, from patient trust and provider safety to digital tools and graded service models. Thank you, sir.
Thank you. The Deputy Summary, which captured the whole session with the track strengthening health systems. We are now going to a question and answer session. Each of you is given 2 questions and 1 minute each. Okay, yes, audience will ask themselves, and each presenter has 2 minutes to address the question.
So please, we want to take, for those of us as part of this audience, we want to take questions from them on any of the topics. If anybody has a question for any of the 8 presenters here, please just indicate so that we ask the questions. Questions for any of our presenters so that we ask them and we'll take it from them.
To the presenter of prostate cancer study update.
Prostate cancer.
So, the paper you have presented, are there strategies that are put in place to mitigate against these difficulties in the adopting of screening? Then to Dr. Kalaba, despite the challenges we are having, have you been able, or did you, I think you have profiled ways you have overcome challenges so that the students spending the required time for their training, they eventually graduate and be able to start to practice what they want to study. Thank you very much.
Alright, so please just take me from the questions. We'll allow Reverend Sister Faulkner to ask a question. Anybody else have questions? Okay. Then we'll take one more so that we just have time to respond.
Thank you very much. My question goes to Dr. Kurema.
Dr. Kurema.
I wanted to know at what point, when does he do this transition from pediatric to adolescent? Because he has stages at least. So we want to know at what point he transitions them to the adult learning.
Okay, at what point you transition from pediatrics to adult? That's the question. The final question. So 3 people have questions. You need your question. Okay. Dr. Fonji, this one.
Your respondent to looking at about in the nature of their jobs, it is beyond the parents that the nature of their jobs, they will not have time for general knowledge to be able to do this to. Why did you choose this specific respondent?
Why did you choose road transport workers regardless of the nature of their jobs? Prof, should you hear, Dr. Kalaba didn't hear your question.
I said it was a nice presentation, but I didn't hear what you provide.
Solutions?
Yes, solutions to overcome a lack of accreditation and then being able to graduate and practice what they are going to do.
Okay.
And I thought that program that is also there. Thank you.
All right, thank you, Prof. So we have 2 questions for Dr. Koji to answer, one for Dr. Kuronya and one for Dr. Kalaba. I guess that's all. Okay, one more.
Thank you, Dr. Kuronya. My question is for you. You talked about the pediatric, the movement from the pediatric to the adult neurology. We're talking about burnout. We're talking about inadequate health workforce. How do you plan for this to actually work What's the plan to implement it? I know your clinic is very busy. How are you going to now have another clinic for transition and a team to do it? Thank you.
I guess it depends on what references to ask that. At what point you transit, this one is saying how you have it. Please, we would love for you guys to just come out so that we can see and hear you. Dr. Okunji first. Thank you, ma'am.
Thank you very much for the question. I think I'll start with the second question. You asked why do you choose the low capital workers? So when we know that patients are tired, we have to find out if these are most of the people who are this low capital workers are men who are aged between 20 to 30, 40, 50. So we have a huge at-risk group in this region. Now, we have been doing a lot of advocacy, a lot of training advocacy, and more of the people who are educated. If you have a same, if you repeat the same study amongst men in the University of UK, you will probably have a higher percentage of students. Even if you don't have higher percentage, you realize that we have more men who have heard about the lab or are aware about English. And most of the time, only 22% of on the end of the station. And this is only 9.3% of students in the United States. So this is like, these are these groups very highly privileged individuals who normally are missing a huge proportion of men and not the proportion of this situation. So in terms of family, what should we find out? So many of them are really interesting. Or many of them don't even know about it. They don't know about it. They don't even have time. So the whole idea is, can we bring this training to them? Is it possible to screen them in the local parks? Is it possible to encourage them that, okay, fine, we're going to have weekend clinics just to answer questions? So clinics now, one of the things I work with is we did an outreach for a particular bus ride. But this was from the church. It was the church that organized this outreach. So can we have more outreach organized? Can we have mobile clinics for women? Clinics that are more accessible. They have motor parks. Is it possible for us to have a hospital clinic in the motor park? Just in kind of areas that help secure other communicable diseases. Can we do things like this for non-communicable like prostate cancer?
Okay, thank you so much. Please let's accept Dr. Okunji. We welcome Dr. Okunji to answer this question. Then Dr. Palaba will take the final word. Okay, very much. Okay, my own.
Thank you very much for the question. The first question was, currently at what point do we transition children from the pediatric clinic to the, I don't know if it was a mistake, at some point you say pediatric to adolescent, and at some point you say pediatric to adult, but I will answer both. The adolescent clinic in the University of Benin Teaching Institute just started, less than 3 months old, and I'm sure it will be an opportunity to collaborate with respect to transition. But currently, two models guide our transition from pediatric urology clinic. Once the child clocks 18, few months before 18, we ideally start having that conversation and do what we call the abrupt transfer. Once they come up by 18, the old system would not accept them because of their age, and so we cannot take them. Usually we would use case notes and do a letter and do an abrupt transfer. However, in this study, we studied 3 models. One of them is an abrupt transfer. The other one is intermittent visits. So they pay a visit to adult clinic, they come back to pediatric until they think that they are ready to transition. While the last one was a collaborative PED-med clinic, and the adolescents themselves prefer a collaborative PED-med clinic. That's for when we transition. The second model that guides our transition currently is control. If the adolescent has already gotten seizure control of the most common case is epilepsy, and we are already on the process of weaning the adolescent off anti-seizure medications, most times we keep beyond 18, so that we can sufficiently just wean him off and let him go to his normal life. Also, some conditions don't have representative models in adult clinic, like cerebral palsy. So you find out that most children with cerebral palsy live longer because there is no representative model in the adult neurology clinic. Thank you. For the question on how do we intend to translate this study to practice, I will start with current best practices say nothing for us without us. That we cannot begin to plan a process without hearing what the end user would prefer. So this first is an opportunity to even get the end user to make a choice. Secondly, with the starting of an adolescent clinic at the University of Benin Teaching Hospital, it gives us opportunity to collaborate, because when these adolescents come to pediatric clinic, they feel uncomfortable. We could collaborate with the adult clinic. And thirdly, which is actually the crux of your question, manpower problem and issues of burnout. It's going to be difficult for me to answer, but let me start with an easier answer. This will be another opportunity to ask for more manpower. This will be, and especially since we have evidence to support our request. Secondly, a few years ago when I was a resident, pediatric neurology clinic had 3 clinics: a Monday clinic for follow-up, a Wednesday clinic for epilepsy, and a Friday clinic for developmental pediatrics. Unfortunately, 2 people left by the Japan syndrome, and Dr. Paula was left alone, so the clinic was collapsed into 2 clinics. I think that it is possible because I worked as an only senior registrar in pediatric neurology with 3 clinics. But more important is that this should be another opportunity to back the request for more manpower with evidence. Thank you.
Thank you, Dr. Kurono. We appreciate your answers. The final one is for Dr. Pablo.
Thank you, sir. According to further earlier researchers that researched on agile project management, they all encountered challenges. And one of the major challenges encountered in UNIMED was migration of students from the school to Western countries and even to other departments. And this is actually affected by pioneer students or pioneer of any establishment. But the school tried to make their stay in the school more engaging and interactive by organizing community outreaches, both in the university and in the environment. So the school provided free buses for them and gave them some incentives, especially providing food for them. And they were also participating in public lectures. They were having workshops, they were having seminars at discounted rates. And they were also involved in audiological screening of new students and new staff into the school. So all this made them engaged, and I believe that was also why the number increased to the maximum of 20%. Thank you, sir.
Thank you very much, Dr. Kalaba. Final comment from our chair and co-chair, and then we'll wrap this up. We'll have a good photograph with participants and the chair and co-chair when we're done. Thank you.
Thank you very much. I want to use this opportunity to thank my co-chair and the presenters for this stimulating session, and it was on track to strengthen the rating system. And we are going through this session and be very, very prevalent. We have a way to strengthen the rating system for pregnant women, for drivers, for the nurses, for the adolescents, usage of the medical records, on ENT, and then infection control through standard precautions. So we have learned a lot of lessons from this session. Now is to put theory to practice, and we can finish our work and publish it in a reputable venue, and then we will still as an academic. Thank you very much.
Thank you, sir.
Thank you once again, Julian presenters, for your very welcome. Mine is an observation, lovely slides, use of AI implementation. I just want to remind us to not to forget ourselves in using AI for our presentations. For many of the presenters, it was quite summarized with you missing out the science of what we're talking about. But with you still remain grounded and capture the essence of what we come to present. I won't be able to go into details because we have been scored, but I hope that the message is passed across. AI is for you, it's a tool for you to use. So once you have used it, you now look at your objective or the task you want to do and make sure you add what is needed to make your work work. For many of us, as a few examples, there were no in-text references. There were no in-text references. You don't make general statements in the said, and we don't have your reference to back it up. Some of us didn't have a reference list at the end. I hope you understand. So that's just a few of observations for you. You can meet me one-on-one for more detailed discussion. Overall, we don't hold on, we kept time, your confidence was intact, and we did well. Thank you.
Thank you very much. Thank you. Thank you, Chair Coach. Please, we'll request that the Chair Coach please join in for group photograph with the presenters. After this, we're going to have a quick ceremony presentation and then we'll have the closing formalities. So please bear with us, we are wrapping up in a bit. After the group photograph, we have ceremony presentation and then we have closing formalities. Thank you. If you don't have it already, presenters just flank the so please. Thank you all very much. The second group is wrapping up and they will come for their pictures once they are done. So we will factor them into the plan. But I think while we're waiting there, just a minute. We should have a second. So the next section, center leader is already here. Every center leader, also this is the cookies, and no cookies will come up stage. So join your center leader and you will Thank you. So we'll have the second presentation run. Once the second group is ready, we will take their pictures once you join us. So we just hold on for them to join us, take their pictures and then have some presentation before we have the closing. Thank you, Prof. Thank you. Thank you, Group 2. Second and specialized session. Oh, thank you, ma'am. Thank you, ma'am. So please, all presenters and the chair and co-chair, Professor Isara, Professor Egiamusoy, and Professor Okade, please join us up here for the picture session so that we can go into the final presentation for today's series, and then we'll be out of here. So all presenters, please just come up stage. The governors are ready. And our moderators, Professor Isara, Professor Yamusora, Professor Fadi, please just join them. Thank you, sir. Thank you, Mark. Please, all presenters, our chair and co-chair, they are already here. All presenters, please. All presenters for the second session, please, just come up.
Including the supporters.
Including supporters.
All the supporters, come.
Supporters, so please join.
Those who supported the presentation, come. The special session. Where is Murphy? Murphy, come on.
Okay, if your numbers are ready, we're ready. Okay, can we get everyone? Thank you very much. Special greetings, Dr. Murphy, Dr. Chichi, and all the trainers in that group. Okay, so our final presentation will be made by the Center of Excellence in Reproductive Health Research Series, University of Benin. We have the chair and the and the deputy chair, or the lead and the deputy lead. How we address it? Lead and deputy lead. Center leader and deputy center leader. Professor Taisiago and Professor Inuku. Thank you so much.
Thank you very much for doing the wonderful work. Good afternoon, ma'ams and sirs. Good afternoon, everyone. Big congratulations to our beautiful chair, Professor Mrs. Rita Momo, for a lovely conference. Well done, please can we appreciate her? Can we celebrate our prof for this opportunity to shine? Thank you, ma'am. And congratulations to the College of Medicine for this 4th scientific conference. So I'm here on the platform of CERI stands for Center of Excellence for Reproductive Health Innovation. And I'm here with my amiable Deputy Center Leader, Professor Mrs. Christy Enuku, for this presentation. What the current status of CERI is what we're about to discuss. And I must thank the Vice Chancellor, Professor Enoma B. Omorige, Senior Advocate of Nigeria, for the opportunity to serve and to take CERI through this new phase. where the emphasis is on research, service, and innovation, especially the part of impacts, making impacts right here in Uniben, impacts in Edo State, and beyond Nigeria even. So in the next 2 minutes, we'll be talking about SERI. SERI has a record of being a World Bank supported African Center of Excellence, over 10 years old now. And what we do is to improve population and reproductive health in West Africa sub-region. It will interest you to know that Nigeria, SERI is the only center that focuses on reproductive health among all the centers supported by World Bank. And that's a unique feature. So we have a record of over 10 years of impact. We have trained over 1,000 students. Our vision is to be a leading institution to provide innovation and transformational change in matters relating to population development and improvement in living standards of citizens in Africa. And our mission is to implement high quality training and apply research for reproductive health professionals. So the programs that we do are as shown. We have master's program. We collaborate with 4 departments: public health and community medicine, obstetrics and gynecology, health economics, and nursing science, to present to you postgraduate programs, both master's and PhD programs, with emphasis in reproductive health as shown. So masters in public health, nursing science, child health nursing, and PhD as well. We have our simulation lab. Our brilliant keynote speaker for today's event talked about a theory practice gap in training our students. I'm happy to announce that SERI is very well positioned to address that gap in our simulation lab. So please let's bring our students to SERI simulation lab. The beautiful thing in our lab is that we have facilitators trained by Harvard staff who train our facilitators and how they can teach our students these skills. So by the time they are on the ward with patients, they are very confident and able to deliver. The coordinator of our simulation lab is Professor Watimat, and he's done excellently well in making sure we have regular trainings for our students. We've trained over 100 students since I became chair and leader of SERI, and the nursing students are also on board. We also have plans in progress to collaborate with them in Delta University, Canadian University, so they also bring their students to come to our simulation lab for skill acquisition. Then we have plans also with the state, the Primary Development Agency, working with the Secretary. So we also train the primary health staff to acquire skills. What are these skills? Neonatal resuscitation, obstetric care. They are available in our SERI lab. These are pictures of work done so far with our participants acquiring skills in delivery technique, CPRO, and the care of the neonates. You can see in these pictures, Dr. Kentobi was the previous one, very efficient, well trained, and Dr. Mokobu, Professor B is one of our facilitators as well, taking care of training the students for breastfeeding to detect early cases of lump in the breast and reduce prevalence of breast cancer by doing that. So these are more of the various things that we teach and train our participants when they come to SERI lab. So we encourage you to let the word out and help us encourage the students to come. We're very willing to work with them to get these skills so that when they come to you on the ward, you have less stress in teaching them the clinical skills because we've done the work for you. For our research lab, we have a very well-equipped research and molecular lab where instruments and equipment are available for you. Are you a researcher? Are you a student thinking of what should I do for my final year project? Please come to us and say, we're ready to work with you and support you. Are you willing to write for grants? We have a structure that when you add us to what you're doing, you are sure to get 90% or 100% even sure to get a positive report, a positive response for whatever project you want to engage in with us collaborating with you. We are equipped for discovery with our semi-auto analyzer, ELISA, incubators, autoclaves, spectrophotometers, and our electrophoresis machines that you can use for various tests as shown on the slide. Our molecular lab is also very, very well strategically positioned to support your research ideas and your growth in your careers. So whatever biomedical and diagnostic assessment you want to do, genomics, biotechnology, come talk to us. We have staff in our lab. Dr. Fidelis Okulafo is also very good and available to provide the necessary support. You can do advanced molecular genomics compatibility from the equipment that we have. Our flow cytometers, PCR machine. Our PCR machine was actually used during the COVID period. That's what was used to identify cases with COVID, and it's still very functional. And we can use it for tests as we wish. So we are able to help students bridge the gap from bench to making breakthroughs, from our hands-on training, equipping them with skills, support for them for their thesis and dissertation. We are also ready to support any career researchers that are bound in this program in hitting their goals. We are available for external collaboration, as I've mentioned. We have a beautiful library that is available for your use. We have functional internet. No cap for the downloads that you want to do. Just come and register with us. Whatever it is, that is your goal. We're ready to support you. Located in a very serene environment, we have functioning laptops and access to high-impact journals that you can use for your research, whether it's local, national, or at a global level. We have a resource hub that can also support you in doing whatever you want to do. Very soon we'll screen our workshops, short courses, to also support us in our career goals. We're not all about research. We also have our service arm, where we also cater to your social needs. We have our sharing halls that you can decorate as you wish. We have our guest house, very affordable, located in a very serene, conducive environment right on campus. We have our international student hostel with fridge, AC, name it, it's available. We have a restaurant on site in Surrey. We have a commercial bus that can take you anywhere you're going within Nigeria. And, of course, our simulation lab, like we talked about. And trust me, there's quality in all this. When you come to us, you will testify as well. So this is our hall. And that's actually the Surrey hall, the one you know. Decorated by this individual in the way he wanted it. And of course, that's the look. So for conferences, birthdays, seminars, lunches, dinners, what do you have to do? We're here for you. And it's very affordable, very, very affordable. In fact, conferences I've held in Surrey, previous conferences we've held in Surrey. So these are pictures of our cafe and our restaurants. Visit us and you will testify. It's a picture of our hostel located down the road from Medical Hostel, and you'll be happy. There's no overcrowding there, neat, spacious, and all utilities that you need is also available. This is a picture of our guest house that you can use to host your guests. So in conclusion, let's build the future of reproductive health together. Terry invites sexual scholars, grant-making bodies, universities, industry to collaborate with us in training, in laboratory research, simulation-based clinical education, and infrastructure development. So how do we collaborate? How can it happen? The first way is joint research and grant proposals. When you come to us, we'll show you more details of how we can work together. Fee-based inter-university simulation training, very affordable. Commission, laboratory and analytical services, facility rentals, hospitality partnership, conference, and event hosting. So get in touch with us. Those are our handles. You can reach me or my lovely deputy center leader, and we're ready to make impacts with you. Thank you very much, my lovely chairman, for the opportunity to speak to the House on this. Thank you.
Thank you for your guys. Also, Enuku should just say something at least so that we make it balanced. The deputy center lead.
Thank you very much. Like Shell said, if you visit us, you will not regret it. You will definitely testify. Thank you.
Thank you, ma'am. We appreciate it. So CERI is available to every one of us. They are ready to help us, whether it's in research, whether it's in relaxing, any area. Okay? So we're bringing this session for today to a close, and we're going to have announcements and more like vote of thanks from a member of the local organizing committee. I want us to put an answer for Professor Emeka Odai, JP. Professor Sak, Emeka Odai, JP. Welcome, sir.
Thank you very much, the MC of this occasion, for your work being well done so far. Good evening, everybody. I greet you in the voice of our chairman, Professor Mrs. Rita Momo. She has asked me to tell you good evening. She's asked me too, on behalf of the LOC, to thank you for your time. We want to appreciate all those that share their science with us. We don't take them for granted. It's well appreciated. The day is fast spent. Tomorrow is another day. The federal government has declared tomorrow a public holiday. But it is important that you know that in as much as there is a public holiday, our program is scheduled to run as on our programs. So tomorrow from 8:30 we will kick off. Please, there was a law before takeoff this morning. Those things have been taken care of, and it is expected that we come early tomorrow. Everything that we need to have the conference kickstart as scheduled is in place, and we hope that we will finish promptly. It's going to be a horrible day. There are lots of things to expect, so please don't miss it. Come early. Every participant who will step in here have a takeaway in cash or in kind. Don't fail to come. The tent outside, you see it, please, is for eating, so that we reduce the chances of eating within the main auditorium and probably causing some death here and there. So when they give you your pack, whether at tea break or at lunchtime and you want to eat, please, you can step out there, you eat and you come back. There's going to be a super duper award session tomorrow. You may be one of the winners, but if you are not, someday will be yours. Please come and join us to applaud the award winners. On that note, I want to thank you once again. Look at our programs. It has been well structured and planned to benefit each and every one of us. We look forward to welcoming you tomorrow. Enjoy the rest of your evening. Thank you.
Thank you very much, sir. Okay, Madam Chair is coming up for one final. Please just a reminder, additional information, tomorrow is public holiday, so we can start in on time. Professor Mrs. Okegome, you're welcome. I want to celebrate Professor Mrs. Okegome. You're welcome.
My nation, you're welcome. Yes, thank you very much, Professor Dan. Thank you, everyone. We can't thank you enough. I even think sometimes it's better to do this talk maybe midway when there are more people. Because tomorrow is our day 2, as rightly spelled out. But I just want to remind us that it actually starts at 8, not 8:30. That may just be an error. So it starts at 8 and it still starts exactly. Because we have a workshop. The workshop 1 session is set to kick off at 9:30 dots. The person that is taking the first 30 minutes is traveling and needs to leave at exactly 10. So we really have to keep to time. So I want to just encourage us to please come early and let's keep to time. And apart from that workshop, we have also the grant writing workshop in the afternoon, and then the interprofessional panel discussion in the afternoon, which we need a lot of participation to really appreciate and benefit from all that is going on. So just to encourage you that since it's a public holiday, take it as time out. Take it as time out to come, enjoy your conference, enjoy your gourmet meal by the catering committee that have done so well, and have a conference outside Benin, in Benin. So see you tomorrow.
Thank you so much, Madam Chair, Professor Rita Momo. Perfect ending with we are done. I just want to appreciate other members of the LOC, Dr. Peter Agborofo, Professor Ria Consi Osagogo, Professor Dumebi Kayoma, Professor Mrs. Osime, Professor Andrew Obi, Professor Rosalind Esewe, Professor Nika Odai, Professor Amina Okaku, Dr. Osayem Otabo Olubo, Dr. Elomo Okonga, Dr. Mrs. Adeyemi Ehizoche, Dr. Chidoke Mokogo, Professor Neka Chukwumagomi, and the Committee Secretary, Ms. Endurance Otote. We thank you all for making this wonderful. We continue tomorrow, 8 o'clock.
Yes.